you, hon. It's really hot and I'm getting really sweaty, even though I have an air conditioner. So things are going to get a little interesting today. Hi, Lorraine. Hi, Sonia. All right. So let me introduce this scatterbrain right here. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. This is our weekly support group meeting. We normally do these every Sunday, barring holidays or me just getting real tired, which happens too. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to be able to disrespect you, to minimize you, to tell you that it is all in your head, because it is not all in your head. It is not all in your head. Here, wait, let me see if I can do this real quick. Let me pop out that chat. There we go. So I got that done. I can do this. That'll be better. Oh, right. Okay. I bring to you 3 college degrees. Not that they mean that much, but I do have a degree in chemistry. I do have a degree in pharmacology, drug development. I also have a master's degree in psychology, and the IC network was actually my doctoral dissertation proposal, which ironically I could not do because driving hurt too much. But anyway, I'm very proud to say that the IC network has been rated #1 in the world by Harvard Medical School and the University of London. For the most accurate, reliable. Sat on the U.S. Army IC research panel for a decade, allocating money for research. And that's where the advantage of being able to have these really complex college degrees was very, very important. I'm also a presidential fellow. So enough about me. When I do these meetings, you know, a lot of people are kind of like, yeah, these glasses are better. Let's see, how do I want to say this? People ask me, why do I do the IC network? Why is this important to me? And despite all the degrees and all that sort of crap, which is at this point in time is kind of crap, I know what it's like to suffer at home alone. I know what it's like to feel left out. I know what it feels like to face question after question after question from people who simply don't get it. I know what it's like to lose your friends. I know what it's like to be in your bedroom begging God to make you better. It is such a profound experience that it changes you. That when you have truly suffered, life becomes very, very different. You know, before IC, before pain, before chronic pain, before all of that, you know, we might have thought that having a fancy home was important. We might have thought that having a fancy car was important, whatever. And you know what? After you've lived with severe pain and you've gotten through it and you're better, all of a sudden your priorities change. You know, it's like, okay, I could care less to have a big house. I live in my parents' house because I care for them now. 98 years old, 92 years old. I was telling my dad this morning, I don't need a big house. I don't want a big house. I don't want to care for a big house. I want a small, happy house. It gave me the gift also of doing work that was truly meaningful, because before I did this, I was never happy in my work. I was never happy being an employee. I was never happy doing work that didn't feel like it was making a difference. I wasn't. And the gift that IC gave to me was an opportunity to do work that I really, really valued. And I'm so incredibly grateful for the opportunity to be here for you and to be a support group leader for you. 28 years and counting. 28 years and counting. And you know, a lot has changed. A lot has changed in the last 28 years. 28 years ago, we thought IC was an incurable bladder disease. Guess what? It's not. It's not. It's a pelvic pain syndrome. Why? Because now we know structures outside of the bladder can cause all the symptoms you associate with the bladder: frequency, urgency, pressure, pain. So I want to tell you the story of a patient I was working with on Friday. You know, I always say this is, you know, working with IC patients sometimes is like getting water out of a desert, or, you know, or finding a needle in a haystack. It is You guys are challenging. And one of the reasons you're challenging is because just like I did, you're going bladder, 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 bladder. I'm up all night peeing. It has to be my bladder. I'm up all night. It hurts when I urinate. It hurts when I do this. It hurts when I do that. It has to be my bladder. It's my bladder. And God forbid you've been going through IC for years. You've been saying, I have IC, I have IC, I have IC for 20 years, right? Or longer. So I was working with a lady who I see for at least 15, 20 years, right? And she was looking for something other than Elmeron because she felt that Elmeron was the only therapy. And now we know, of course, that Elmeron is associated with retinal disease and eye disease, and she didn't want to do that. So it's like, okay, so whenever I'm working with you guys, I always take a step back and it's like, okay, let's just revisit this diagnosis for a moment. To give, we can't talk about the right therapy for you until we know or what your therapeutic options are until we know what your biology is, what your anatomy is. And you guys, you have to remember, I can't give you medical advice. My job here is to open doors. I want to open as many doors as possible for you to explore, especially for those of you who are not responding to therapy, or especially for those of you who are newly diagnosed. So, she wasn't. So, clue number one is that she wasn't diet sensitive. And she's going bladder, 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 bladder. And it's like, but wait a second. You can eat anything and you don't flare? And she goes, yeah. I was like, well, it's not your bladder then. She's like, yeah, of course it's my bladder. And it's like, nope. Because if you can eat anything that you want and you can do coffee every day and you don't flare, then it's not your bladder. And she's like, it has to be my bladder, it has to be my bladder. And I said, listen, if you have wounds on your bladder, acid in your urine is going to irritate those wounds. You're eating and drinking the most acidic things we know. And you're not flaring. What does that tell us? It tells us that your bladder wall is healthy. Your bladder wall is absolutely healthy. And she's like, oh, and it's like, okay, so let's take a step back and let's go back to when your symptoms began. And so it's like, tell me what was happening back then. And she's like, well, I had foot surgery. I've had a couple of foot surgeries. It's like, oh, isn't that interesting? So what's wrong with your feet? And I don't remember exactly what it was, but it was repaired. And so we started talking about the subtypes, and we started talking about IC subtype 3 pelvic floor driven. And here's what we knew is that when she went to physical therapy, her muscles were a wreck. They were absolutely a wreck. Her muscles were screwed up big time. But she didn't make the connection. She really, really didn't make the connection. So she said, well, I did it a couple of times. It didn't help me. It's like, okay. So, it's like, okay, are your muscles tight? She goes, yeah. And I said, well, what are you doing about it? She goes, nothing. And I said, well, do you realize what that's doing to your pelvis? Do you realize what that's doing to your bladder? She's like, no. And I said, well, it's restricting blood flow. It's compromising nerves. So maybe we need to look at this again. And then I told her, I said, listen, we had a research study a year ago, which showed that 70% of men with testicular pain had an underlying hip abnormality. And she's like, oh, okay. So we're just talking. And I'm really trying to make the point. I'm really, really trying to make this point. And an hour later, she goes, well, I guess I should tell you that I have hip pain. An hour into the discussion. And she's fighting me at every opportunity, saying, it's my bladder, it's my bladder, it's my bladder. And I'm going, you can eat anything. It's not your bladder. And then, building this case for pelvic floor dysfunction, IC subtype 3, and even IC subtype 4, pudendal neuralgia, right? And she's not giving me anything. It's like, okay. Yeah, I had a bad foot. Okay. Do you walk normally? No. Okay. So anyway, at the very end of this conversation, it's like, yeah, I guess I should tell you that I do have bad pain in my left hip. I'm just like going, okay, so why am I saying that? Why am I saying that, guys? Dr. Jerome Weiss, let me get his book here. Let's see. Hold on. I should have prepped, but I've been running. Okay, so Dr. Jerome Weiss has written the most amazing book, Breaking Through Chronic Pelvic Pain. This is a love letter to IC patients. This is a love letter to pelvic pain patients. His goal, it took him 15 years to write this book. Custom illustrations, everything. I mean, it's just so freaking good. So when he was a urologist out here in San Francisco, and back in the 70s, he saw that bladder therapies didn't help a lot of patients. They didn't. And he's like, why? Why don't bladder therapies work for a bladder disease? And so he took a step back and he started looking at muscles. It's like, okay, if the patient is responding to bladder therapy, let's see if there's something else involved. And what we do know is if you go back 100 years in the research studies, you see doctors, urologists describing muscles so tight, they're like tight piano strings. And so, he looked at cause and effect, I mean, he like made the connection. He goes, okay, well, we know these tight piano strings aren't correct. We know these tight piano strings are certainly abnormal. So he dived into muscles and ligaments and fascia, and he became really the first national expert in pelvic floor muscle issues, right? That good. I remember him 25 years ago coming to conferences, and I remember the doctors kind of rolling their eyes, but now, he was right all along. And in 2008, we had our first National Institutes of Health IC study, which found that pelvic floor physical therapy outperformed bladder therapy. So this is proven in major federal research. So we know this is a reality here. So anyway, here you go, Dr. Weiss, an absolute expert at muscles and fascia. If you walked into his clinic with tight muscles, you would walk out that day with as normal of muscle tone as you could have. He was that good, an absolute master at manipulating tissue. What baffled him is why did it come back in a week or a month? Especially trigger points, because trigger points are big muscle knots, right? And so why did the muscle knots come back in the same location a week later, 2 weeks later, 3 weeks later, a month later, same exact spot? And that's when he took another step back and asked, okay, well, what puts pressure on and tension on muscles, but bones and ligaments? So he started looking at bony structure abnormalities. So does this patient have a bad SI joint like I do, right? Which would cause their muscles to be tight. Does this patient have a tailbone injury? I was working with a patient again on Friday whose tailbone was absolutely out of position. They knew that 100%. Does this patient have a bad hip? Because if you've got a bad hip and you got one hip higher than the other, then your pelvic floor muscles are out of balance and they're not working together. And it also makes sense to look at the knees. It makes sense to look at the knees because if you got a bad knee, you're limping, right? Like my mom, she does the right. I mean, she's 92. That's what happens. And that puts terrible pressure on her pelvic floor. But the pièce de résistance, the last connection that turned out to be the connection for 90% of his patients who had long-term chronic pelvic floor tension was how are you walking? He calls it, you're revealing layers. We're just revealing layers. So if you got a bad foot, you got plantar fasciitis, you got shin splints, you got Morton's toe, you got neuromas in your feet, you got bunions, whatever. If you got an ankle that turns in, an ankle that turns out, that is going to, over time, create kind of a wear and tear injury. And he talks about this in the book, where, when you're a teenager in your 20s and you were a super athlete, like I was a really mega athlete. My workout was 100 flights of stairs a day. I would then go swim a couple miles, and then I would row 5 miles. And I did that like almost every day for 10 years, not having a clue I was blowing out my feet too. Not having a clue that doing all that Stairmaster, I was actually destroying the fat pads in my feet, which is why I now wear Hokas every day. So, wear and tear injury. So when you're young and you get hurt, your body's extremely resilient, and subtle little differences, your body can compensate for. But by the time you're in your 30s or in your 40s, the wear and tear injuries start to emerge. If you have one leg longer than the other, you might be fine when you're a teenager in your 20s, but in your 30s, you're going to start to see little tweaks here and there with muscles. And so I want you to look at this picture. Now, this leg is the normal leg. And if we go straight up and we follow the bones straight up, and I don't know if you can see this muscle right here that's connecting. Okay. See that muscle right there, right above my finger? That's a piriformis muscle. Okay, so this is a healthy leg. Now look at this leg. This foot, the ankle turns in. Okay. Now look at what that's doing to the femur. That's pushing the femur farther out, and it's stretching and tweaking the piriformis muscle much more. And we're seeing all sorts of other kind of issues. Healthy side, abnormal side. And so getting back to this lady I'm working with, it's like, all right, now wait a second. You were diagnosed with IC 15 years ago. Bladder therapies have never worked. You can eat anything you want to eat and nothing flares you. And yet you want to take Elmeron. Why? Because it's my bladder. But honey, it's not your bladder if you can eat anything. And introducing the concept of muscles to her was challenging. She fought me at every direction. And I bring out the research, and I bring out the pictures, and I bring out everything. And it's like, okay, did you suffer any trauma 15 years ago? And she had. And it was very clear that her muscles were a dominant part of her symptoms. So anyway, I sent her off back to her pelvic floor physical therapist, and also to get this book, because she needed to read this book. I forget what her injury. She had a really weird injury. It was definitely part of a tailbone injury with something else going on. So our goal here with one of the reasons why I like to do these meetings is I want you to understand that this is a pelvic pain syndrome, and there can be other things triggering your symptoms. Sometimes the bladder is a victim of another dysfunction in the pelvis. You could have a fibroid tumor pushing on your bladder. You could have endometriosis attached to your bladder. You could have a Tarlov cyst coming off of your sacrum. Or you could have posterior phonic syndrome. There you go. Posterior phonic syndrome. What the hell is that? This is something I learned. If you read my blog over on the IC Network last week, I put up a new blog. And it was about a woman with Hunner's lesions who was cured after they did a suspension surgery for a prolapse. And it turns out that let's see, I wish I could describe this. You know where the uterus and the cervix meets the vagina? And it's not like a square, right? That the cervix actually comes into the vagina, and the vagina actually goes slightly past the cervix on the front side and the back side. These are called phonixes. I hope I got that right. I was saying fugax. It's not fugax. It's like phonix, something like that. It's over on our website. So you have two little tiny pockets on the front side and the back side of your cervix. And if you have suffered a ligament tear, your vagina can twist. Your vagina can twist. And the way that they test for this is they put a wooden speculum up there. And if they can put a speculum up on your posterior phonix, and if they lift it up and your symptoms go away, you have a ligament injury. You have a ligament injury. It's just, so here we have a woman, severe Hunter's lesions, she's got a severe prolapse. They go in to surgically repair it. And what do you think happens? Her lesions disappear. Like, holy hell, what the hell? That's a first. And this is published, I think, in the Journal of International Urology. Anyway, it's over on the front page of our website, icnetwork.org. So understand that if you are newly diagnosed, you are on a journey. We are trying to figure out what the hell could be triggering you. And the same sense as if you are a veteran IC patient, you were diagnosed 20, 30 years ago, and you think you have a bladder disease, but you haven't gotten any better, it's time to take a step back and let's see if we missed something. Did you miss something? You'd be amazed at the things that have been missed. You'd be amazed at the things that you've been missed. All right. So guys, I just need to go check on my, I care for my elderly parents. I got to go check on my mom really quick because she was not doing too well this morning. So give me a minute. Okay. Quick potty break. All right. Oh, the poor thing. Thank you for your patience. Thank you for your patience. She was sitting at the table waiting for somebody to give her breakfast because my dad forgot to do that. I had it all prepped. I think I'm going to write a book on the top 10 things you learn when you care for elderly parents. Number one, they lose their sense of thirst. They lose their sense of hunger. They eat one meal a day. She's got to have her food. All right. Okay, so let's get back on track here. So the way we do these meetings is I take your questions. I'll take your questions for the next hour, and then we'll go into Zoom, and then we'll come back to Facebook and YouTube. we'll see how things go. We did have an earthquake last night, so I do have a record of having 2 live earthquakes during live meetings. So it's always an adventure. It's not a real meeting if something doesn't fall. All right, let's go over to Facebook here. So we are broadcasting live on YouTube and Facebook. So I've been looking over here. I'm just looking at my Facebook thing. And then if I'm looking here, I'm looking at YouTube. Barbara says, what is the theme for IC Awareness Month this year? I have no freaking clue. I have no idea because I've been working on this, the new book, IC 101. Anne says, my physical therapist said my left side is off. Exactly. So, if you're right-handed, that what happens is that your left side of your pelvic floor takes more pressure. So it's very common for people who are right-handed to have left side pelvic floor dysfunction. If you're left-handed, to have right side pelvic floor dysfunction. That was something I learned. Annie says, I've had a severe flare-up since getting the vaccine. Does anyone else have problems with the vaccine? Annie, that's a great question. I'm going to say that probably 80 to 90% of IC patients who get the vaccine have no problem, but about 10% do report flares. Lorraine says, I'm now going to David Josephine at Cedars, 5 stars. Lorraine, please, if you can, do me a favor and please submit his name so that we can add him to our database. Thank you, Annie. Thank you, Patty. Lorraine says, have you ever thought about suicide? Lorraine, I think anybody who's faced with a new diagnosis, who's faced with intense pain, who is not getting the support they need, their mind will go there. I think that that's fairly normal, but there's a difference between going, oh, it would be easier if I weren't here, than, okay, let me make a plan to decide how not to be here. Suicide, this is a very tricky area. I want to tell anybody who's watching this that if you are having suicidal thoughts, you need to tell your doctor immediately. And if you need to, and if you're really in a crisis, you need to call your local suicide awareness hotline, because they are there. They're so good. They are good at connecting you with good resources in your community. They often know who the good pain doctors are, et cetera, et cetera. And when you're feeling alone and when you're feeling like there's no hope, I think that it's quite common for people to think that. I certainly did. I can tell you the exact day. I couldn't sit, I couldn't stand, I couldn't walk, I couldn't lay down. All I could do was pace because my pain was so severe. But I told my doctor, and I got to the emergency room, and I got pain care. And remember, guys, for those of you who know me, I had a doctor tell me I would live in pain for the rest of my life and it would be very, very severe pain. He was effing wrong. And when he said that to me, he said, you will be a burden on your family. You will be a burden on your family. Get used to it. This is your life. You will always be in pain. And that's what woke me up. And I went, wait a second. Wait a minute. Wait a freaking minute. I'm going to prove you wrong, you son of a bitch. How dare you say that to me? And that was the moment I started fighting back. And I'm really grateful for that jerk. He was an absolute jerk at the moment for saying that to me, because that's when I said, all right, I got something to prove here. I'm going to prove him wrong. And that's when I started diving into the research. That's when I attended my first support group meeting. A couple weeks later, started my own support group because I didn't have one close to me. And that singular moment is what turned me around and made me get better. But it always begins with your knowledge. You have to learn. And that means you got to read. You got to be able to talk to doctors about what the structures are in your pelvis. Where is your pain? Is it low? Is it high? Is it inside your body? Is it outside your body? Is it to the left? Is it to the right? What makes the pain better? What makes the pain worse? All that sort of stuff. Your ability to talk about your symptoms is going to greatly impact your success in getting medical care. And guess what? God didn't give you the skills to understand IC when you were born. You have to learn about it. You got to read about it. You have to read about it. Information is power. Information, the more information you have, the better you will be able to ask for help and to direct your medical care. Because remember, you pay them. They don't pay you. You pay them. You're the boss. You're the one making the decisions. And I need you to walk in so strong, so knowledgeable, so informed. You're going to look them in the eye and say, all right, let's talk about it. I want to hear the pros and cons. I want to hear what my treatment options are. I want you to study my body and tell me what you think is triggering my symptoms. The worst thing you can do is walk into a doctor's office and just say, I'm fine, as my mother does. I'm fine. No, you're not. You're at the doctor. What's wrong? I'm fine. No, really, you're at the doctor. You made an appointment. Why are you here? Well, I can't sleep through the night. Okay, what's going on? Well, I just can't sleep at night. Okay, why? What's going on? Are you getting up? Yeah, I am. Okay. Are you getting up to urinate? Yes, I am. Okay. How often do you do that? Oh, a few times. No, really. How often do you do that? Well, I really do that like once every 30 minutes. Okay. So you're doing that a lot. You're doing that a lot. The more information you can share with your doctor, the better. But there comes a point in time when you are emotionally exhausted. You have never worked as hard as you are working right now, and you're doing it alone in all likelihood. And that's why having a support group is important, so that you can see, look, here's Jill. She's gone through the exact same thing. I'm not alone. And look at all the people in these meetings. Our videos have been seen almost 1 million times. We work with patients in 92 countries. You are not freaking alone. You're not. Nor are you the worst patient. I thought I was the worst patient in California. I thought it was the worst patient in the country in the summer of 1993. For sure, 100% thought I was the worst patient. Started my support group. Started working with other patients. Went, oh, I'm really not. Wow, I actually have it pretty good compared to some other people. Context matters. But again, if you're at the point where anxiety is out of control, where you're just emotionally exhausted and you need somebody to talk to, or if you're having, dark thoughts, it's important to ask for help. And there's no shame in asking to see a pain specialist, a psychologist, a psychiatrist, because you've never done this before. They've helped thousands of patients through this. There is wisdom to be learned. And, the thing about talking with somebody is sometimes you get along great, and it's the perfect person for you. And sometimes, no connection. Move on. Go to another one. Go to another one. Be the squeaky wheel, my friends. You got to be the squeaky wheel. This is real. Here, hold on. It's so hot. They told us it's going to be 113. Oh. So let me just do this real quick. Whoops. Hold on. All right. Let's see here. Lorraine says, who cares about money? Happiness is the absence of pain. Well, listen, here's the other thing. It's amazing the things that you can do from home to make a little bit of extra money too. It's amazing. If you like to take pictures, you can submit your pictures to iStock Photo and get a commission when people use it. If you like to design things, you can design things at Teespring and sell t-shirts. If you like to write, contact me, because I'm always looking for writers. I'm always looking for, I love working with patients. If you have a marketable idea that you think would be helpful for IC patients, call me. I will sign an NDA, so don't tell anybody about it if you want. But I would like to help you with that, because I had people help me. And listen, when I was fighting, I was absolutely determined. It's like people think because you're disabled, you're not going to be a good employee. And it's exactly the wrong. Man, when you're disabled and you've got something to prove, you want to work because you want the health insurance, and you need a paycheck. Being disabled with IC doesn't mean that you can't work. Being disabled with IC doesn't mean that you don't have ideas and things like that. You do. Look at that. I started a website. I was a chemist. I took one class, started a website, now rated #1 in the world. If I can do it, you can do it. I mean, like, seriously, get pissed off and let's take some action here. And I hope that isn't offensive to some of you. I apologize if it is. Laura says, can you speak to kidney infections? I get them constantly. I take D-mannose and colloidal silver, which helps tremendously, but how can I prevent them? The docs have not been helpful. I am not a kidney expert at all in any way, shape, or form. Allura, the over-the-counter options that are the most popular really for the prevention of urinary tract infections is Allura or Prevent. And so if you haven't seen Prevent, these are PAC products. Proanthocyanidins are the active ingredient in cranberry that help to flush E. coli from the bladder. And so Prevent is PACs with D-mannose in it, but it's not acidic. You don't have to worry about acid levels with Allura or Prevent. But, hon, you got to talk to a kidney doctor about that. I am just not an expert in any way, shape, or form. Billy says, I can't stand for any amount of time. I get nauseous. Does anybody else have that problem? No, Billy, that is not a symptom of IC at all. That's unusual. I will tell you that I have gone through periods of time when, okay, y'all know I have no shame. I will pretty much talk about anything. And I had IBS. I mean, I'm IC subtype 3, IC subtype 5. So what does that mean? I've got pelvic floor dysfunction, and I've got chronic overlapping pain conditions. So I had IC, IBS, vulvodynia, TMJ, which has been out of control the last 6 months, etc. And that's a central nervous system dysfunction. And I've talked about that before. And if somebody asks, we can talk about that again. But what that means is that my central nervous system is remarkably sensitive. It's easier to trigger it. It's easier to turn it on. So we have sensitive, very sensitive skin. We've got bladder sensitivity, stomach sensitivity, bowel sensitivity, et cetera, et cetera. I can tell you, again, no shame, that I have had periods where I have had a bowel movement and then got nauseated afterwards. And that's some sort of vagal nerve something. It doesn't happen often, but it used to happen more when my IBS was really active. And my IBS is completely controlled, just like my IC is now. So I think you need to talk to your doctor about that. You could have POTS, POTS, which is an issue when you go from sitting to standing where you get dizzy. Maybe that's part of it. Maybe that's going on for you. I'm not sure. Lorraine says Valium works better than opiates. I take 40 milligrams at night. So Lorraine, you're talking completely different method of action. If Valium is working for you, that's because Valium is a muscle relaxant. And so what that's doing is that is kind of creating a foundation for you to be able to sleep more comfortably. I take Flexeril at night for my TMJ and for my pelvic floor. I take a quarter of a pill of the lowest dose. I take very, very little. But if I'm starting to feel those muscles getting jacked up, the first thing that I whip out is a skeletal muscle relaxant, and that's what Valium is, and that's what Flexeril is, and that's what Baclofen is. So that's interesting. It's treating your muscles rather than your spinal cord for pain, and that's kind of telling us that then maybe your muscles are part of the problem, if not the problem. Carla says, I'm on week 2 of my pelvic floor therapy. She says, I'm doing great. Nonetheless, I'm still trying to accept this unexpected change. Carla, people get hurt. You got hurt. No shame, no blame. You got hurt. And it'd be nice to try to know what caused the injury. I mean, were you riding a bicycle? Were you, did you have a pregnancy that strained or stressed or injured your pelvic floor? Were you an athlete? Et cetera, et cetera. Those are all things that create the foundation for a pelvic floor issue. So no shame, no blame, hon. You just got hurt. But healing happens. Healing can happen, especially with pelvic floor. That's what Dr. Payne said when he proposed his 5 subtypes of IC. Yvonne says, who can we see in Georgia? Yvonne, towards the end of the meeting, I'll whip out the doctor database and we can go look at that. Marie says, when I go to a chiropractor, because I also have one leg shorter than the other, and it makes my pelvis shift, which then makes it feel like I have a bladder issue. And when they fix it, it goes away. But unfortunately now I have that and I see. So Marie, this is really the book for you, hon. This would be a good starting place for you to try to understand how and why having one leg longer than the other creates long-term imbalance in your hips, creates long-term tension in your pelvic floor, which eventually, through what we call the Somato visceral reflex, starts to irritate your bladder. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved. They are two interconnected. And so our goal here is to try to figure out which one is primary and which one is secondary, because normally one is driving the other. So for some of you, IC begins after a legitimate bladder injury, let's say chemotherapy. You're going through chemo, it's fried your bladder wall, your bladder's screaming in pain, and your muscles are getting tight to protect you. Okay, that's called the guarding reflex. So our therapeutic priority for the chemo patient or the patient who is exposed to ketamine or industrial chemicals, or if you are a terrible diet soda drinker and drink too much diet soda or coffee, our therapeutic priority for that group of patients is to calm and soothe the bladder. Calm and soothe the bladder. If we do that, eventually the bladder pain should reduce and the muscles should relax and things will get better. Diet is important in somebody who has a bladder wall injury. But think about the patient whose symptoms began after a fall or after having a baby or after a traumatic injury of some type, falling on your tailbone. So you've fallen. It's like, yeah, my tailbone hurts. And yeah, it hurt for a week, right? It hurt for a week, but then it went away. But then all of a sudden you've got bladder symptoms, frequency, urgency. It's like, what the hell? You call the doctor. Doctor, I think I have infection. The doctor goes, okay, give us your urine. Let's test it. We'll throw you some antibiotics ahead of time. So they throw you on antibiotics. They don't work. Your doctor calls you back. Guess what? There's no infection. And you go, well, it's got to be an infection. Well, I'm peeing all the time. The doctor goes, oh, let's just give you antibiotics anyway. Why don't you take this antibiotic for 3 months, 6 months? Let's see what happens. It doesn't work. You go back to the doctor. The doctor goes, you know what? I think you have overactive bladder. They try overactive bladder medications like ditropan, Detrol. They don't work. You go back to the doctor because it's painful now. It's over time, it's become painful. Overactive bladder patients usually don't have pain. IC patients have pain. That's how we distinguish that, right? So now you've got pain. You go back to the doctor and the doctor goes, God, I hate to tell this to you, but I think you might have this really awful disease called interstitial cystitis. It's an incurable bladder disease. Here's the diet. Here's Elmeron. Send you on the way. And so you're a good girl, good guy. You go home. You do the diet. You do the Elmeron. But you're not getting better. And before you know it, a year has passed. 2 years have passed. 5 years have passed. You have a couple bladder installations. Yeah, don't do that much. 10 years have passed. 15 years have passed. And you're not better. You're not better. Why? Because your symptoms are the result of a muscle injury. So what happens, and bladder therapies will never work for this person. You will never get better on bladder therapies if you've got long-term pelvic floor dysfunction. If you've got a tailbone out of position because it was broken, bladder therapies will not fix that, period. End of story. It will not fix that. The consequence of tight muscles is profound because when you have tight muscles, it restricts blood flow to the bladder. If the bladder normally gets 28 units of blood a day, and because your muscles are so tight, your bladder's only getting 10 units a day, is your bladder wall going to be healthy? No, it's not. If you've got trigger points are long-term compression injuries. Trigger points are devastating because trigger points not only compromise blood flow, they compromise nerves. And then you're stuck with a lot of nerve dysfunction. Look at this picture. This is a trigger point. These are two really good pictures of trigger points. Look at what that is doing right there. You can see right here, it is interfering with blood, the blood vessel. So this is the blood vessel, and you can see how the blood vessel is being compressed. And then it's also going to interfere with the blood vessels that support the nerves. Nerves need good blood supply. If nerves don't have good blood supply, they can't work well. If you cut off the blood supply to a nerve, the nerve will die, or at least become extremely injured. So our therapeutic priority for this group of patients is to restore blood supply. And how do we do that? We do that with pelvic floor physical therapy. And again, in 2008, our first National Institutes of Health funded major pelvic floor study found that pelvic floor physical therapy was remarkably successful at reducing the symptoms of IC, even more so than most bladder therapies. So that's not me, that's the National Institutes of Health, and they're right. They're right. And this is one of the reasons why I wrote this book with Gay and Andrew Sandler, IC 101. It was just released last weekend. IC 101, it's not just a bladder disease. Our goal is to help those of you who are not getting better on bladder therapies figure out why. Why? Because for many of you, like the lady I started talking about, it begins with something other than the bladder. And so this is a class, IC 101. I want you to think of it like a college class that will help you understand the variety in the IC patient population. It will help you understand why online support groups can be painful rather than helpful, because you're mixing apples and oranges, because you've got some people with viral infections, other people with chemotherapy, some people with tailbone injuries, other people with bad hips in the same group comparing their therapies when you can't compare them because they're different, right? God forbid you be having a really bad day because you really jacked your hip up, and you go online and you see somebody who's got a really bad bladder wall because they're drinking coffee every day and they've got Hunter's lesions, and you're going, oh my God, I don't want that to happen to me. Well, it's not going to happen to you. You have a muscle injury. You have a muscle injury. We have to work on that. So IC 101, it's not just a bladder disease. It's now available in our store. It's $9.99 for the e-copy, $24.99 for the print copy. It costs $17 to print this, guys. Okay, so it's not like this is a big money maker. This is just this is the foundation for a big work we're going to be doing in the coming 6 months. So Marie, getting back to you, when you go to the chiropractor and they balance your pelvis, your symptoms get better. There you go. Suzanne says, does the book talk about Hunters? Absolutely, it talks about Hunters. Yvonne says, would a gynecologist be the one to diagnose? You know, as Dr. Weiss says in his book, this is where Western medicine fails the pelvic pain patient, because doctors like to stay in their sandbox. Some doctors, urologists tend to stay in the urinary tract, gynecologists tend to stay in the reproductive tract, et cetera, et cetera. And the challenge with the pelvis is it's a small confined area that has a lot of stuff going on. So you've got organs, you got blood vessels, you got nerves, you got muscles, all interacting. And often it's about relationships. It's about one structure impeding another structure. And so that's why a fibroid tumor pushing on your bladder would cause symptoms, because there's not a lot of space in this little pelvic cavity you and I have. So in many cases, it's about relationships, how it's the muscles affecting the organs, how are the organs affecting the muscles, how are the nerves affecting the organs and the muscles, et cetera, et cetera. Terry says, prayers for your mom. Thank you. Patty says, I'm at 5 months post-hysterectomy and so far 1,000% better. Only a few mild pelvic floor flares since. I really owe this to you, since because of you, I learned to ask good questions that got me on the right path. Yeah, baby. I love it. I love it. I love that you were able to go back to your doctor and ask better questions. I don't want anybody to give up. For God's sake, don't give up. This is a really exciting time right now. It's an exciting time because we've learned so much. You know, they're getting so much better at making a diagnosis. They're getting so much better at finding the right treatments for you. This is the last time for you to give up. There's a lot of good things happening right now. And doctors are getting it. They're slowly but surely getting it. You know, granted, the national experts, the regional experts are completely together on the muscles. But I was working again with a patient last week whose doctor told her pelvic floor physical therapy didn't work. At which point in time, I emailed her the research study that proved that it worked. So, all right, Terry says, I've been having these needle pricks going on the left down low. It's just been recent. I haven't been to the doctor yet for this. Yeah, Terry, so that's a pudendal neuralgia. I've had the same thing. That means that you have muscles so tight, they're squeezing nerves, and it can be very positional. You might be fine when you stand, but when you sit down, you get pinpricks. Laura says, can you buy the book on Amazon? Not yet. I haven't put it up on Amazon yet. I will this week, undoubtedly. I just, check some, they're just have to do things in sequence here. We'll also have a Kindle book, and we'll also, I'm going to record an audiobook too. I'm not going to hire somebody to do the audiobook because they're going to have a hard time pronouncing words, and I can pronounce the words. So, Terry, those pins and needles, not at all surprising. A couple of years ago, I had something really interesting happen. Now, I had my hysterectomy 4 years ago, and it left me with really, really messed up muscles. I had involuntary muscle spasms for 10 months, and I had to get into physical therapy to stop the spasms. But every now and then I feel the spasms again, like I felt them this morning a little bit, which is when I get my glass wand and I've got to do my thing. But so I had this really weird thing happen where it felt like I was being stabbed by a needle on my labia, like right around my hairline, of my pubic hairline. Sometimes it'd be on the left side, sometimes it'd be on the right side, but it kind of started up front. And then over a period of a week, it went all the way back towards my rectum, just random little pins and needles, like in my vulva, in my labia. So I go to the doctor and I'm going, okay, it's got to be yeast. First doctor I see at urgent care goes, yeah, I think it's yeast. He did a big swab. He goes, I think I see yeast. They threw me on yeast meds for a couple of weeks. Didn't work. Go to my gynecologist. She looks and I'm bright red down there, like bloody red down there. That's how bad it was. So I go to my regular gynecologist and she goes, gosh, you know what? This looks like eczema. She did a vulvar biopsy, never fun. Came back. She goes, I think it's really eczema. And so she put me on massive steroids. So I did steroid like clobetasol and stuff like that for a month. Didn't get better. In fact, it was getting worse. And I finally just said, listen, I want to talk to your pelvic pain doctor. And so I got a voice appointment with the pelvic pain doctor in San Francisco. And like in 2 minutes, she goes, Jill, I know exactly what you have. It's your muscles again. They're squeezing a nerve. This is a pudendal neuralgia. And I was like, I didn't know pudendal neuralgia can cause vulva symptoms. I associate pudendal neuralgia with sciatica, maybe with PGAD, persistent genital arousal disorder, but not like pins and needles on your skin. And she goes, oh yeah, we see it all the time. And I go, okay, what do we do? She goes, you're going to go back to pelvic floor physical therapy. And that's what we did. And yes, my muscles were super, super tight. And it was the pelvic floor physical therapy combined with a little bit of lidocaine to calm the nerves on the skin that fixed it. So, things present in really weird ways. Here, hold on a sec. Marie says, I noticed that my belly is really bloated. They say it's a bladder belly. Does it go away? Yes. That's the IC belly. You can wake up with a flat stomach and 3 hours later look 6 months pregnant, and then hours later it goes away. That's very classic. Lorraine said she was finally given pain medicine and that helped her with her suicidal thoughts. Exactly. Exactly. I had no pain meds my first year, none. And then ended up at the emergency room and they actually gave me a shot and it turned my pain off. And I went, what? You can turn this off? Yeah, that helped. That really helped. But again, guys, that was 1993. Patty says, I had a gynecologist tell me I just have to live with the pain endometriosis was causing me. I'm glad I didn't listen to her. Yeah, baby. Lorraine says doctors do not like empowered patients, especially dislike lawyers. Hey, you know what? You're right. And you know who they dislike the most? Other doctors with IC. You want to talk people getting totally disrespected? Other medical care providers who go for help because of their pelvic pain. The single most important phone call I have gotten in my career was from a man who was sobbing. Like, I answered the phone. Hi, this is Jill, IC Network. Can I help you? Yeah, you know that because that's how I answer the phone, right? And there was this man sobbing, like sobbing. And so I spent like 5 minutes just whispering to him and deep breaths and just kind of getting him through that moment. What he said stunned me. He said, I am the chief of one of the biggest trauma units on the East Coast, and I have pain, and I have IC, and I have told no one because they all laugh about it. They think it's psychological. And the minute I tell them, I will lose any respect they have for me. And then he started sobbing again. And he said, I can't do this anymore. And because of him, we started a confidential support group for medical care providers with IC, because believe it or not, there are quite a few of them, especially nurses. Lorraine says, the videos of people telling their stories, they never cry. How is it they don't cry when telling their story? I always do. Lorraine, if you watch my hysterectomy cancer video, you'll see sobbing. I don't know. I mean, like when I do videos, I'm going to be doing a lot of videos for the rest of the year. I'm angry when I do my videos. I don't cry. I'm angry. I'm assertive. I really want I want them to be really productive. Hannah said, I had a bad flare-up last week. Even doing a bladder installation was painful, painful and hard. Now the pain is gone, but so bloated, you can't go. It's like a very, very slow flow, and it's not fully emptying. So, Hannah, two things come to mind with that. Number one of the well-known complications of having a bladder installation is sometimes that pushes bacteria into your bladder, and you could have a bladder infection. And so you need to let the doctor know that immediately after you had the installation, you're having more issues. So concept number one is, could you have a bladder infection from the installation, from the catheter? But the second thing is tight pelvic floor muscles. When you're in pain, your body protects you by tightening muscles, and you've got levator ani muscles right around your urethra. If those muscles are tight, it's going to be hard for you to start your urine stream, right? So that would be the other thing I would be looking at is, because you've been in so much pain, of course your muscles are going to be tight. That's the guarding reflex. And that's really, guys, that's just really a good way on a day-to-day basis for you to kind of monitor the health of your pelvic floor. If you can go pee, if you go to the bathroom and you can pee right away, power to you. That means your pelvic floor is nice and relaxed. If you try to go to the bathroom and you've got to wait 5, 10, 15, 20, 30 seconds before you can release urine, bam, that means your muscles are probably tight. And if you find that your stream is very slow, start, stop and start, stop and start, that also kind of means that your pelvic floor might be tight. Deborah says, sometimes talking about my IC makes me flare. I get that. I think that's real, honey. I think that that's absolutely real. I think that when you're under stress and talking about your IC is stressful, your body is going into fight or flight. You can't stop that. You know, this has been an anxiety producing, an anxiety painful experience for you, or an anxious painful experience for you. And so, of course, your brain is thinking that your life is at stake. It's triggering fight or flight. Fight or flight raises your heart rate, raises your blood pressure, and tightens your muscles. Then one of the first muscle groups that starts to get tight in fight or flight is your pelvic floor, because your brain thinks that you're going to have to fight for your life or run for your life. And it has to tighten the pelvic floor to get you ready for that, because your pelvic floor plays a big role in how you walk. So there you go. Patrick. Hey, Patrick. My wife is the strongest person I know dealing with IC in her daily life. Hope you all can stay strong too, and these doctors figure something out. I can't believe they don't even know what causes. But Patrick, we do know. We do know what causes it. It's not one thing. It's not one thing. The IC patient population is remarkably diverse. For some people, IC begins in childhood. For others, IC begins after menopause. Are they the same? No, they're not. For some people, IC begins after chemotherapy, while for others, IC begins after having a baby or being raped. Are they the same? Absolutely not. And you really see the diversity in what the bladder looks like. Because for a lot of us, the bladder looks completely normal. My bladder looks completely normal. And yet I had very severe pain when I was first diagnosed. Okay. And yet for others, the bladder is covered with big bloody wounds. So is somebody with a normal bladder and somebody with Hunner's lesions, the bloody wounds, the same? Absolutely not. So what we're doing now is subtyping. We're trying to find the variant. We're trying to figure out which variation you might be in to make sure that we have the right therapies for that specific variant, so that you don't waste 20 years taking Elmeron when your fundamental problem is tight pelvic floor muscles, if that makes sense. Cara, thank you so much for the 50 stars. I really appreciate it. Yvonne says flexural helps her too. Hannah says there are 5 subtypes. Yes, there are at least 5 subtypes. In Europe, they use 12 different subtypes or variants. Melanie says TMI, but every time she's intimate, she turns bright red down there. Yeah, that makes sense. Well, you're also getting good blood flow down there too, which can happen. Hannah, yes. I use a subtyping system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University for 25 years. He released his subtypes 5 years ago. And one of the things that he railed about were patients who were told that IC was an incurable bladder disease, because in fact, some patients are curable. And so he broke the IC patient population down into 5 fundamental subtypes. Subtype number 1, Hunner's lesions. And let me just get my... Everybody in the world, every IC researcher, doctor, nurse, everybody agrees that IC subtype 1, Hunner's lesions, is its own unique patient group, because these patients have bloody wounds on their bladder wall. Okay, so there, and the wounds can bleed, they can hemorrhage. It's called a waterfall effect, that when they stretch the bladder, and if a patient has Hunner's lesions, these injuries or these lesions or wounds bleed profusely like a waterfall. So Hunner's lesions are their own unique group, and there is a movement across the world to actually split them off and create its own unique disease category. We have a couple of theories on what causes Hunner's lesions. The first is some research from Europe that patients with Hunner's lesions may actually have viral infections in the bladder wall. We know that the bladder wall can be infected with viruses. We know that certain viruses, specifically polyoma viruses, are associated with hemorrhagic cystitis. Hunner's lesions can hemorrhage. There you go. So there are 3 or 4 studies from Europe that associate viral infections with Hunner's lesions, and they don't find the virus in patients without lesions. So that's concept number 1, viral infection. Concept number 2 is that it's a neuroinflammation, that when nerves get super, super, super irritated, they release a substance called substance P, which damages tissue. And one of the kind of rationales for this, although there's a much more academic explanation, is that when you infuse the bladder 24 hours a day with lidocaine, the lesions go away. And what does lidocaine do? It numbs nerves. So there is a medical device called Lyris that actually heals Hunner's lesions in 2 weeks. It's like a soft, hollow piece of spaghetti filled with lidocaine. They stick it up in your bladder. It sits in your bladder for 2 weeks, and it releases lidocaine 24 hours a day. That was originally created for pain, but they were stunned in their very first research study up in Canada that patients with Hunner's lesions responded stunningly well to lidocaine therapy, and in fact, their lesions disappeared. The quote in the research study was a complete and total resolution of the bladder. So that's theory number 2, is that it's a nerve stuck in the on position. And of course, viruses live on nerves, so that doesn't exclude viral infection also potentially. And then, of course, we have the case study that was released a couple weeks ago. Now we have a woman who had posterior phonic syndrome. She had a damaged ligament. And when they corrected the ligament and corrected her prolapse, her lesions went away. And I don't understand the mechanism of action there, but that is a published case study. So Hunner's lesions, IC subtype 1. IC subtype 2, bladder wall driven. So these are the patients who have a legitimate bladder issue. Nobody's saying that for some of you it's not, but bladder. For some of you it is. So if you're going through chemotherapy, chemicals injure the bladder wall. So ketamine, chemotherapy, or drinking, too much coffee or soda, right? That constant daily acid infusion eventually starts to erode the bladder wall. So we know your bladder wall is driving your symptoms if you have pain as your bladder fills with urine that is relieved by urination. And let me see here. So here is a picture. This is a picture of an irritated bladder wall. Okay, these are what we call glomerations. Now, so wherever you see red, you basically see wound. You see an area, a sensitive area in the bladder wall. Now imagine your bladder starts filling with urine. And that urine is now going into that wound. It hurts. So the fuller you get, bam, 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 bam. The worse you feel, ow, find it. I need a bathroom now. Get the fuck out of my way. Excuse me for swearing. I'm sorry. But anyway, I do. Bam, you pee. It's gone. You feel better. Why? Why? Because urine is no longer touching the wound. And again, I apologize for swearing. It pops out every now and then. I blame COVID and the last 4 years. All right. So what causes this? What would cause this? There are 3 kind of fundamental groups in this subtype. The first one is going to be chemical injury. The second one is going to be estrogen atrophy. Estrogen atrophy. Your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. And the purpose of that mucus is to protect the tissue. Well, unfortunately, that mucus is estrogen dependent. So when you're young and you have lots of estrogen, you have lots of mucus and you can get away with stuff. When you're older, you have much less estrogen, much less mucus, And your bladder wall is basically much thinner and much less able to defend itself. It's called estrogen atrophy. So if your symptoms began after having after having a hysterectomy, or they put you on Lupron and in your 20s, you are in artificial menopause or chemical induced menopause, or if your symptoms began in your 40s or 50s and you have no history of trauma or anything like that, the very, very first thing we're going to look at is the quality and health of your skin. Your bladder needs estrogen to be healthy. When you lose estrogen, your bladder is less able to protect itself. And this is why in your 30s, you were able to get away with Starbucks throughout the day. You were fine. And all of a sudden in your mid to late 40s, you can't do that anymore. That's not a disease. That's estrogen atrophy. That's aging. And so therapeutically for this group of patients, the first thing we're going to consider is really going to be using a topical estrogen product, an estrogen cream, an estradiol cream. Because when you give that skin when you give that skin estrogen, it starts to produce mucus. Now, also understand that the urethra is kind of like the canary in the coal mine when it comes to estrogen atrophy. It's the urethra that's the first part of the urinary tract that will start screaming because it's gotten a bit too dry. And it will feel like there's a drop of urine stuck in your urethra that will not come out. Okay, so if you're having a lot of urethral pain, or you feel like there's a drop in there and you're in your 40s, 50s, 60s, very first thing we want to look at is your skin. If your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. The third thing we want to consider in this subtype, in this bladder wall subtype, is chronic infection. Yes, because chronic infection happens. It can happen. But the question is, what kind of infection? What kind of infection? Because when you think bladder infection, you're thinking bacteria. Well, guess what? Guess what? Our own National Institutes of Health discovered, in fact, that some patients who are flaring because they have yeast infections in their bladder. They have fungal infections in their bladder. And now we know we can have viral infections in the bladder, but the fungal infections are more common. And so if you're having all the symptoms of infection and you go to the doctor and they do a urine culture and they say no infection, your answer is, all right, did you test for fungus? Did you test for fungus? And you can find that data right on our website. You can print out that research study, give it to your doctor and say, hey, especially if you flare when you eat sugar or carbs or ice cream, things like that, things with milk sugar in them really cause yeast to grow. So if you notice that you flare when you eat sweets, that really points us directly to potential fungal infections in the bladder. Okay. Now, there's going to be more subtypes in this group. I think that there's a hormone subtype in this group, but they're just not well defined right now. IC subtype 3 is pelvic floor driven. This is the biggest subtype, in my opinion. These are the patients whose symptoms began not because of a bladder injury, but because of a muscle trauma. Something's going on with their muscles, as we talked about earlier. So they could have taken a direct trauma, like if you were a gymnast or an ice skater, or God forbid, a ballerina. You want to talk people who have really messed up pelvic floors? Ballerinas, aging ballerinas. Holy moly, do they struggle with tight muscles. And so for these patients, they don't necessarily have pain as their bladder fills with urine. They tend to have pain after they're done peeing. So if we ask you the question, when is your pain the worst, before you pee or after you're done peeing? If your pain is worse after you're done peeing, we're really going to look more at muscles. And of course, the classic symptom that we look for is, can you start your urine stream right away, or do you hesitate? If you can go to the bathroom, sit on the toilet, or stand in front of the toilet and release urine immediately, then your pelvic floor is probably pretty good. But if you're sitting there or standing there for 5, 10, 15, 20, 30 seconds, that means your muscles are not relaxing well enough and could be tight. And so that's where we look at pelvic floor. So obviously with these patients, we're not going to be focusing on bladder therapies. We're going to be focusing on muscle therapies. That's why if you have a flare because you had sex, that sex-induced flare, even though you've got intense frequency urgency, your bladder's fine. It's your muscles that are spasming. So pelvic floor flares require a different rescue plan. With a pelvic floor flare, We're not going to be worrying about drinking water and diluting your urine and alkalinizing your urine. We're going to be relaxing muscles. So you're going to be using heat, you're potentially muscle relaxant, stretches, using a glass wand, et cetera, et cetera. And you can find our pelvic floor rescue plan in this book, IC 101, along with our bladder wall rescue plan. But you can also get those in your flare management guide. So if you're a member of the IC network, just go onto your member page, and you can download your flare management guide. It's 40 pages. I'm rewriting it right now, rewriting all the guides right now. They will be done shortly. And so bladder, pelvic floor, bladder, pelvic floor. Laura says, can some people have subtypes? It's normal to have multiple subtypes, because if you have Hunner's lesions, which are extremely painful, you're going to have tight muscles. So the thing is yeah, okay, so you got Hunner's lesions. So let's say we treat the lesions, they get lasered, the lesions heal. The legacy, though, is you might still have tight pelvic floor muscles that have never been treated. So we want to make sure those get treated too. Hannah says, I took my gallbladder out before I got diagnosed and have very bad tingling, numbness, pain in my hands to my shoulder. Now you also have PCOS, almost never. Yeah, you have polycystic ovarian syndrome. Really? Or POTS syndrome. Hannah, one of my original group members, Linda, had a really, really wicked flare, and she went to our local community hospital, and she was crying and saying, it's my bladder, it's my bladder. And they went, no, it's your gallbladder, it's your gallbladder. And they did emergency surgery. They pulled it out, and guess what? It was perfect. It was healthy, completely healthy. And that's common, that patients have had inappropriate hysterectomies when their problem was with their bladder, et cetera, et cetera. So the tingling, numbness, pain in your hands to shoulder, obviously that's not connected to your IC at all. You need to go back to your surgeon and or a neurologist and try to figure that out. Marlene says, where can you buy the book? You can buy it from the IC Network, our website, icnetwork.org. Lorraine said, would hysterectomy help with IC as there would be more room in the pelvis? Absolutely not. No. Hysterectomy would not help with IC unless you've got giant fibroid tumors pushing on your bladder. We do know that if a fibroid tumor is pushing on your bladder, the best thing to do is to remove that, but they can either treat the fibroid or surgically remove the fibroid. And in some cases, if it's really, really severe, they might do a hysterectomy. The problem with hysterectomies is that you're actually traumatizing tissue more, potentially. There's a condition called vaginal apex pain, which is what I had after mine, where the incision at the top of your vagina, where your cervix used to be, becomes hyper sensitive. And so, and certainly you want your ovaries. You don't want to be thrown into menopause. If you can keep your ovaries, you want to keep your ovaries because your bladder needs that estrogen. And for anybody out there pondering hysterectomy, there's a fabulous website, hystersisters.com. I recommend to everyone. Rhonda says, what kind of doctor tests for pudendal neuralgia, and can this also cause restless leg syndrome? A doctor that would test for pudendal neuralgia would be an OBGYN and or a neurologist, and it's really about experience level. My OBGYN was certainly able to do that, but my old OBGYN, who's now retired, is the one who figured everything out. But my new younger OBGYN, she was messed up. She missed it completely. So it's really about their expertise. And would it cause restless leg syndrome? I'm not sure. Lorraine says, I studied with my son for all of his med school questions, and there was only one measly question on IC. He got it right, but it's sad that med students are taught. And he bupkis about IC. Yeah, it was like 10 years ago that the first IC question was put on the oral board exam for doctors. So more and more doctor education is happening, But understand that a lot of that's changing. They're really, if you go to the American Urology Association conference, which is the largest urology association in the world, usually about 25,000 urologists come from around the world to somewhere in the United States to attend. They started teaching pelvic pain muscle classes about 7, 8 years ago, 9 years ago, somewhere in there. I've summarized several of them in our summer IC Optimists. Usually I go to those meetings if I can, and I take all the classes associated with IC, and then I bring back all the materials and I try to write good articles on them. Last year, we didn't have a conference because of COVID, and this year, the conference was moved from May to September and is in Las Vegas, and I have not decided if that's going to be worth it. I think that the COVID variant D is going to hit us pretty hard in later this summer. So I'm not prepared to get on a plane right now. Lorraine says, Lorraine is asking if Vicky Ratner is still practicing. Not that I know of. I don't think she's practiced in years. She was an orthopedic surgeon, and she founded the second ICA. The first Interstitial Cystitis Association was founded in California, Southern California, by 3 patients of Dr. Lowell Parsons, led by Barbara Flanagan, who is a friend of mine. Then a year later, Vicky Ratner came along, and she started the ICA of New York. And so she started a sister organization in New York that ended up becoming the ICA when the California group folded. And then I came along 10 years later and started the IC network. But I was a support group leader for the ICA for 2 years first. But I don't think, I don't talk with her. We're not friends. So, but I don't think she has practiced in some time. She's older than me. So, and I'm 60. So how did that happen? How freaking did that happen? I was 32 when this started for me. I was 33 when I started my first support group. I'll be 61 in a month. God, that's so weird. Hannah says, I see Dr. Evans at Wake Forest. Should I mention to them the muscles, Hannah? Dr. Robert Evans is literally the best IC doctor in the nation. And so if you're seeing him, he has absolutely already checked your muscles, but you can ask him to check again. I mean, Dr. Evans has voted has been voted the top IC doctor by patients ever since we started doing that. And he was the top IC doctor last year too. Jeannie said, and I have good news about Dr. Robert Evans, and that is that he is not planning on retiring anytime soon. We need our good doctors. We need those veteran doctors who have seen thousands of patients. Their skills at diagnosing IC and all the variants of IC are so incredibly important. Jeannie says, I have bladder wall-driven and pelvic floor-driven IC. I just had a cystoscopy done, and as soon as the water was started, blood droplets were coming from the bladder. I could see them. I was peeing blood for a while, but now they're a little better. Doctor wants to do a hydrodistension. Would this be a good option for me? I think so. I mean, if I'm bleeding, I want somebody to look at it and tell me what the hell is bleeding. I mean, and the thing is, Jeannie, is if you have Hunner's lesions, they can treat the lesion at the time. Generally, what they do is laser therapy or heat therapy, and they will close the wound. Remember, a Hunner's lesion is a big, bloody, open wound. Oh gosh, I didn't finish my subtypes. So these are Hunner's lesions, right? So they're characterized by having a center with lines radiating from it. And you can see that this is a very, very different from this. Okay, let me finish on my subtypes. Sorry about that. I see subtype 4, pudendal neuralgia. So these are the patients who have nerves. So we've talked about bladder wall, we've talked about muscles. Now we have to talk about nerves. Pudendal neuralgia means that there is something interfering with nerve functionality, usually tight muscles. So these are the patients who have sciatica, pins and needles, a vibration. If you're sitting down and you feel something fluttering in your butt cheek, like I do right now, I have a little tiny flutter in my left butt cheek. That is a sign that a nerve is being compromised. So therapeutically for these patients, our goal is to release the nerve, which is getting back to pelvic floor physical therapy, as well as therapies that might calm the nerves down, like gabapentin, also known as Neurontin, et cetera, et cetera. Amitriptyline in low doses can help calm and stabilize nerves too. They might even do topicals, like a topical lidocaine cream or a subcutaneous lidocaine infusion, something like that, to kind of calm the nerves down. That's why when I had my little pins and needles thing, not only did they give me physical therapy, they gave me an estrogen jelly with lidocaine in it to use on my skin to calm those nerves down, pudendal neuralgia. So again, these patients are very positional. They're fine when they stand, but when they sit down, it hurts, or they get a shooting pain down the leg, or pins and needles, et cetera, et cetera. Okay. The last subtype is, I think, the most dynamic subtype. It is called central sensitization, also known as chronic overlapping pain conditions. So why do I see patients get vulvodynia, irritable bowel, TMJ, fibromyalgia? There is a substantial group of us, I'm in the subtype, who have multiple pain conditions. And the question is why? Now we know why. That in essence, it's a central nervous system processing disorder. That our central nervous system is driving the pain because it's become extremely sensitive. So we have very sensitive skin. Like I can't wear wool, I can't wear textures, I have to turn my nightgown inside out. So I don't have, just the little sleeve here will drive me crazy sometimes if they use the wrong thread. And we tend, the other symptom that's so interesting is we have a really wicked sense of smell. We can smell things that other people can't smell, and smells really drive us crazy. So if you have a wicked sense of smell, you're not alone, and that's explainable. And it's explainable in two ways. We now know that 66% of these patients, myself included, have something called small fiber polyneuropathy. Small fibers are the smallest in diameter nerves in our body, and they are common in the skin, and that's why we have such sensitive skin. But they're also common in the bladder wall and in the bowel. And sometimes this is inherited. This is definitely inherited in my case. Every woman in my family, going back generations, has this. This wicked sense of smell. Hello, redhead. It kind of makes sense here. But sometimes that neuropathy happens because of traumatic injury. So if you were in a car accident, if you took a hard fall, sometimes the nerves get changed that way. We also know the other really big finding with chronic overlapping pain conditions is that they've done a lot of brain studies now. And I didn't really talk about the brain studies early on because I didn't really understand them. And frankly, I didn't want to talk about the brain. I thought it was a little scary. But I attended the International Pelvic Pain Society meeting last fall, and it explained it, and it doesn't scare me at all. What the brain studies show in patients with chronic overlapping pain conditions is that our brain is stuck in fight or flight. So what is fight or flight? Fight or flight is the mechanism by which your brain tries to protect your life if you're under threat. So normally, when you're not under threat, things are peaceful. Your parasympathetic nervous system is controlling your day. You're calm, you're relaxed, your muscles are normal, life is good. And then you open your front door and look at that. There's a tiger across the street. What do you think is going to happen? You're startled. Whoa, there's a tiger. or in my case, let's just say fire, right? Because we're in a big fire alert right now. Okay, so open the front door. Oh God, there's a fire right there. And there was a fire right there last year. So our brain goes into overdrive, right? So it's preparing us to fight or flight. It believes that our life is at stake. So what does it do? Raises our heart rate, raises our blood pressure, tightens our muscles, because it's sincerely trying to save our lives. And what those brain studies show is that the amygdala, which is the part of the brain that controls that, is not turning off. Normally, once the stressor has passed, things calm down. And that's because the parasympathetic nervous system takes over and reduces your blood pressure and reduces your heart rate and relaxes your muscles. But for us, we're stuck there. And there's great news here. The great news here is we know how to fix it. If we fix it with mind-body medicine, I can get into that later. But the most important class at the International Pain Society meeting that I took was on pediatric risk factors. Why does this happen to some kids and not other kids? Because I was in 7th grade when this started. Okay, and I broke my tailbone in 7th grade. I totally remember that. So what they found is that 80% of the kids who experienced multiple pain conditions had a major physical trauma in the year prior to the onset of their multiple pain conditions. Being hit by a car, breaking a leg, falling on their tailbone, something like that, okay? 20% of those kids were either being abused or bullied. And so the bullying is the best way to think about it. Think about what that would do to your brain and to your nervous system, because there are a lot of consequences to bullying. Bullying is not like you can walk away and be normal. Bullying changes things. So how does it change things? I want you to think about a 3rd grader who has a bully in their class who's really aggressive and hits them and makes them cry every day. Okay, and let's just say the school is ignoring it, which schools still do. Shock of shocks. So here you have a child who on Saturday, great day. Sunday, not quite as good of a day because they know they have to go to school on Monday. So Sunday night, mom says, come on, let's get ready for bed. Got to go to bed because you got to go to school tomorrow. And so that's when their brain kicks on and they start getting scared. So they do hopefully they will sleep through the night, but when they wake up in the morning, mom or dad comes in, all right, honey, come on, you got to get up. It's time for school. And that's when fight or flight kicks in for that child. That child is scared. Their heart rate is up, their blood pressure is up, their muscles are tight. Mom and dad don't realize it. They don't see it. They drop the child off at school and that child walks in. I mean, as they're driving up to the school, the child's looking out the window, looking for the bully. They get out of the car. They're looking for the bully. They walk down the hallway. They're looking for the bully. They're scared. They're walking to the classroom. They're looking for the bully. On recess, they're looking for the bully. When they go to the bathroom, they're looking for the bully. They're scared. They're freaking scared. And their brain is in fight or flight all day long. The only time they relax is when they get home and they walk in their front door. That's their peace because the bully can't get them anymore. And then they eat dinner and then mom says, hey, you got to go to bed. Got to go to school tomorrow. Triggers it all over again. So think about how that would change the brain and your nervous system over time. So what happens is that the brain the central nervous system basically gets stuck in fight or flight. You're stuck with your heart racing, your blood pressure up, and your muscles tight. And that's what they see in those brain scans. They see a massive fight or flight happening. That amygdala is firing like nobody's business. And so what the research shows is that 20 days of bullying changes brain function for the worse. different parts of the brain turn on, other parts of the brain turn off, the speed and the ability with which different portions of the brain communicate with each other change. There's a real physical change in what happens to the central nervous system under bullying. So 20 days of bullying, that's when they start seeing changes in brain function. In contrast, 20 days of mind-body medicine reverses that change for the better. So you don't assume that it's permanent. It's not permanent. It's just that you're stuck. And so some of you have been stuck for decades. And how do we know that? Because you're anxious all the time. You have massive anxiety. Girl, you have got catastrophizing down to a T. And if you pay attention to your thoughts, literally every other thought is a negative thought. And it's brutal. But now we know why that happens. And remember, too, that pain that is accompanied by anxiety is going to be intensified by the brain because your brain thinks your life is at stake. Pain that is accompanied by laughter is minimized by the brain because your brain goes, oh, she's laughing, your life's not at stake. And so one absolutely critical part of pain, of care for those of us who have multiple pain conditions is mind-body medicine and anxiety management. And I think that that's what turned me around. I found the best anxiety course in my mid-30s at Kaiser Permanente called Phobies. And ever since I've taken that class, I have not had anxiety. I went through a uterine cancer emergency surgery, didn't have a single panic attack because I know to pay attention and I know what to do. And I have a video on our website, icnetwork.com, in our Living with IC video series that talks about that. So if you've got chronic overlapping pain conditions, you could do bladder therapies for years, and it might help a few of the symptoms, but it's not going to fix the underlying problem because the underlying problem appears to be a central nervous system malprocessing disorder. They call it a maladaptive process, but we can fix it. We can fix it. You need to carry hope in your heart. This is fixable with what we call mind-body medicine. And so what mind-body medicine means is that we're going to stimulate our brain in a different way to get the parasympathetic nervous system to take over. We're going to do things that focus on senses because that's how your brain functions. Your brain pays attention to what are you looking at, what are you hearing, what are you tasting, what are you touching, is it hot, et cetera, et cetera. And that's how your brain processes information. It's based upon your 5 senses. And so the way we redirect the brain back into peace and we get the sympathetic nervous system to turn off is by incorporating things that stimulate our senses. We might do tapping, where we tap different parts of our body and we're focusing our brain to pay attention to touch. Or we might do I Spy or something like that. And we can do that. We can do that later on. God, guys, I've been talking like mad. Normally we would go, you know what? I'll start the Zoom meeting in 8 minutes. We'll start the Zoom meeting at 2:30 if anybody wants to do Zoom. But I think we're kind of I feel like I'm on a roll here right now. Lorraine said, is type 2 where glomulations appear in the cystoscope? Yes, but you should know that glomulations, these, just so you know, these have now been thrown out as a diagnostic criteria. Why? Because we now know that the test itself can cause this. And we knew this in 2000 and, was it 19? See, the AUA guidelines were released in 2011, and that's where they kind of hemmed and hawed on it. They've thrown them out at the last AUA meeting as being meaningful at all. But back in 1987, when the National Institutes of Health created their first diagnostic criteria for IC, they required that these be seen or Hunter's lesion be seen to make a diagnosis of IC. And what happened is, like, within a year, a doctor took healthy women with no bladder symptoms and did a hydrodistension and found that they all had them too, but they had no IC symptoms. And what that meant is, and what they believe is, that when you stretch the bladder, you're actually causing this also. So this can be a byproduct of having your bladder stretched, or it can be a legitimate sign that your bladder wall is irritated, but it's not considered particularly meaningful anymore. Do I sell the glass wand in our store? Yes, it's called IC Relief over on our website. This is the one that I personally use. It's called IC Magic or Easy Magic by IC Relief, and it has a curve in it. And the curve is really important because the curve helps you reach muscles. And hold on a sec. Let me get my... So let me give you my explanation as to why this is so important. Okay, so look. Here's your pelvic cavity. So I want you to visualize it as a three-sided box. So we got muscles along the base. We got muscles that come up the front and the sides, right? Okay. And you've got three layers. You know, I didn't say that right. How did they say that? How did they say that? Am I holding this wrong? No, I'm holding this right. Well, the three-sided box analogy definitely works. I don't know. I'm sorry. I just had something flicker through my brain. My brain has absorbed so much IC trivia and muscle trivia. It's ridiculous. Anyway, look. Let's look at the muscles here for a moment. Look, you got muscles on the bottom, right? And there are three layers of muscles. So think about the knuckles on your finger. You got deep muscles. You got middle depth muscles, and you've got shallow muscles, right? And so if we put on your levator ani muscles, so here are your levator ani muscles, okay, and look at this. The levator ani muscles play a very unique role in the human body because they control major bodily functions, because they have in a woman 3 holes and in a man 2 holes. You got a hole for your rectum, a hole for your vagina, and a hole for your urethra. Now, if these muscles are tight, what do you think is going to happen? It's going to squeeze things. That is why pelvic floor dysfunction is associated with constipation. It's very hard to have a bowel movement if you got tight freaking muscles. And guess what? In addition to letting things out of your body, it's hard to let things inside of your body if your muscles are tight. That's why having sex can be painful in people who have tight pelvic floor muscles. And with the urethra, obviously, if your muscles are super, super tight, you're going to have a hard time relaxing those muscles, and or you might feel like you have a urethral stricture. It might feel like you're peeing through a needle because those muscles are so tight. So learning to use a wand is a really important part of therapy. So I'm going to take off the levators. Here's my wand, and obviously, you're not going to be able to get your finger this deep. It's just impossible. But look, you can get this deeper. And you can see, look at how I'm rubbing that. See, it's a J shape, right? So here's the center. And you follow kind of like a reverse J. It kind of goes flat along the bottom, and then you go up the sides. And that's one of the things that the physical therapist might have you do if you have tight pelvic floor muscles, and you can do the same thing on the other side. And sometimes they might have you instead kind of rub in the opposite direction of the muscle. They might have you push on a trigger point to try to get that point to release. But having a glass wand is so helpful. You know, because listen, we need you to be independent, not dependent. If you start feeling your muscles get tight, you might not be able to get into your physical therapist for 2 months. But seriously, you have the ability to do something about that yourself, and that is with a glass wand. And your physical therapist can teach you how to use a glass wand. You can't just buy it and do it yourself. That's not good. Listen, everybody's anatomy is different. You got a lot of different muscles down there, a lot of different potential problems down there. And ultimately, you really need to see a physical therapist at least once so they can tell you which muscle group is involved. And then, if you can't afford to go to the physical therapist, or if it's not covered by your insurance, try to pay for that appointment out of pocket so that you've got a landscape of, at least we know where you're working. I mean, where the dysfunction is. And at the same time, see if they will give you some exercises that you can do and or teach you how to use a wand so that you can check in maybe once every 6 months if it's just financially impossible. But you can't really just do it on your own to start with. I mean, I did not understand how to use my wand until I read Breaking Through Chronic Pelvic Pain, and I had a much better understanding in my brain of what I was touching. Because my physical therapist kept saying, it's a J shape, it's a J shape. I'm like going, I don't get the J shape. I don't understand the J shape. And it wasn't until I got that book and I really tried to understand where the muscles were located that I understood the J shape and I understood the three-sided box analogy. See, I got this little tidbit about something with the muscles going through my brain right now, and it's not coming to me. It'll come to me eventually. Somebody is asking about Dr. Evans. He is at Wake Forest, and he also has a private practice. Just Google Robert Evans Urology. Beth says, I have hysterectomy and ovaries are gone, so I have no hormones. Does this make my IC worse? Yes, it does, Beth. It absolutely does. That's called estrogen atrophy. If your bladder doesn't have good estrogen, it cannot produce mucus. That's called the genitourinary syndrome of menopause. Lucinda says, when will the book be available? Later this summer. Christy says, I was just diagnosed with IC and I'm still learning the diet. Does anyone know where I can get recipes? Yes, you can get the recipes right on our website, Christy. Just go over to icnetwork.org, and the book you can get is let's see. Where is, okay, I'm missing. There are 3 cookbooks. The most recent one and the one that you can get very easily is called the IC Chef Cookbook. And this is actually something that we did about 6-7 years ago. It also has the full IC diet in it. Just tons of recipes, breakfast, lunch, dinner, dessert, special occasions. And these were recipes that were submitted to our IC Chef project over on our website. So these have all been tried and tested by IC patients. So the IC Chef Cookbook, if you're an IC Network member at the $100 range, you get this for free in your member page. All right. We have 3 memberships on the IC Network, $25, $50, and $100. The first cookbook that, started this wonderful process for us is called The Taste of the Good Life, a cookbook for an IC diet. Unfortunately, it's out of print. It was written by Bev Lauman, but she did write a huge column for us on the IC diet over on our website. We have probably 50 different blogs from her, each with lots of recipes. So it's called Fresh Taste by Bev. And you can go over on our website or you can go to icdietproject.com. icdietproject.com is one of our sister websites, and it's only recipes. And that is, they're done by me, by Bev Lauman, and by Julie Beyer, the first registered dietitian who's had a strong interest in IC. And she also has a cookbook called Confident Choices, a cookbook for IC and OAB, and that's available in our store too. All right. So Christy, you can get a lot of stuff for free right on our website. You don't have to pay for anything. Marie says, oh my God, I just said I have a crazy sense of smell and TMJ and more. Wow. Yeah, Marie. Hey, we're sisters. Hi, Gay. What are the pros and cons of pelvic floor physical therapists? Is the therapy painful? That's a great question. Now listen, When you go to a pelvic floor physical therapist for your first appointment, their job is to study your body. And that's what they're going to do. They're going to have you walk up and down a hallway. They're going to measure your legs. You're going to talk to them about your symptoms. They're going to do an internal examination too. No sweat. It's no big deal. If they, during that appointment, during their examination, touch a muscle and it hurts, that is what I call a hallelujah moment. That is fantastic. That is great news, because if they can touch something and reproduce your symptoms, that means they found it. Hallelujah. What are you touching right now? Please tell me what you're touching. So you cannot be afraid of pain at that first appointment. Pain is actually important. If they can touch it and trigger pain, that is fantastic news. The challenge is that some patients misinterpret that and they get scared and they never go back. And that is a terrible mistake. If your muscles have been messed up for years, they're going to be painful at first, but muscles respond beautifully to muscle therapy. We have to start working those muscles correctly. Imagine imagine being in a cast for 6 months and muscles that get atrophied. Say you break your back and you're in a big cast. When they take that cast off, those muscles are weak and they're fragile and they're painful. You're not just going to take pain meds. We're going to try to work on healing the damage done to those muscles. And that's what pelvic floor physical therapy does. We have a couple of really great books, but the most important book is this one, Marlene, Breaking Through Chronic Pelvic Pain. Okay, so let me do this. Let me start up the Zoom meeting and let's just see if anybody wants to Zoom. If you want to, that's great. If you don't want to, that's fine. I'll keep taking questions. I've got no sweat either way. So give me a moment. The way you get into the Zoom portion of the meeting is you go to our website, icnetwork.org, go to support, right underneath the logo, streamed support group meetings. And then you click on the Zoom meeting link, which is what I'm doing right now. I am launching the meeting right now.
Recording in progress.
Okay, we're not going to record. Don't worry. I'm going to turn it off.
Recording stopped.
Okay, so I don't keep any Zoom recordings. Any, your face and stuff like that, but your voice will be recorded on the regular chat, Facebook and YouTube. So if you don't want anybody to hear your voice or hear your story, then don't come into Zoom. So let me give you a link. All right, so here we go, YouTube. Here is, Elise wants to know when my birthday is. My birthday is July 12th. I'm a moon child. All right, now Facebook, let me get you your link. Hold on a sec. All righty, so Facebook. I can see the Facebook. Oh boy, that's hysterical, you guys. You've been looking. There you go. That a little better. Oh, that's it. See, we got two cameras. I've got a low camera and a high camera because we're the YouTube stream is on Comcast. The Facebook stream is on AT&T. All right, so there you go. All right, so let's see if anybody wants to Zoom it up today. If not, that's fine, but this is your chance to get some coaching. All right, so we got one person, Christine, coming. Let me get a drink of water here. All right. Oh, and here comes Lorraine and Jackie. All righty, Christine. Hello, my friend. How are you doing today? Can you unmute yourself?
I'm here.
Hey, girl, how is life? How are you doing right now?
Oh, man. Eye-opener today.
Okay, what's going on? What can I help you with?
Oh, I'm hearing echo here.
Wouldn't be from me. I have to have the voice up. I mean, I have to have the audio up so that people on Facebook and YouTube can hear what you're saying. So,
Oh, I'm here.
okay, hon. Well, what can I help you with you today? What is going on? How is your IC?
This, I don't know. I'm just blown away by your talk today. Like you're talking to me.
Well, this is what I do every day. You know, I mean, in the end, I'm a support group leader. And, oh, hey, Lorraine, it's icnetwork.org. icnetwork.org, not icnetwork.com. Somebody stole that domain from me 25 years ago. icnetwork.org.
I used the link that you sent,
Good.
so that worked.
Okay.
The link worked, yeah.
All right. Okay, so Christine, getting back to you, Christine, what subtype do you think you are?
I think I'm 3 and 5, but
Okay.
when I first diagnosed, I mean, I full on had sensitivities to foods, to beverages.
Yep.
I had the frequency, the urgency, and everything.
Yeah.
But I do have a history of trauma to my tailbone,
Yeah.
back accidents,
Yeah.
and I think it's so much a part of the relaxing of the muscles, and it just hasn't happened for me yet.
Well, I think, you know, there's a time issue. You know, in addition to genetics, I mean, so genetics are real. So, I mean, I have no doubt that I inherited central sensitization because my sister has it, my mother has it, my grandmother, my aunts, my cousin. You know, we grew up not being able to use bubble bath. We already knew bubble bath irritated people, right? So there is a section of this that's just genetic. And for most people who have that wicked sense of smell, we already intuitively know that there's an issue. And the odds are you're probably already doing things to make things better. You're probably not doing scented candles in your home, Febreze in your home, oven cleaners in your home. Stuff.
Oh, yeah, for sure. I mean, that's inherited. My mom had it. My grandma had it. It's all the sensitivities. Like, yeah.
Yeah.
Same thing.
Yeah.
Now fibromyalgia on top of it is just like, but it all makes sense now.
It does. It does. And so you've got to work on calming your central nervous system. I would get our last January Icy Optimist magazine. It goes into this in depth. The odds are you're struggling with anxiety every single day.
Yep.
24 hours a day. And so goal number one, you have to understand that when you're anxious, every time you have a negative thought, you get a jolt of adrenaline, which is just amping everything up. So goal number one is to control that adrenaline. And that's what the phobia class taught me was we have to reduce the overall level of adrenaline in our bloodstream, which is stimulating so much of that stress and so much of that illness. I mean, not illness, but the upset stomach and the diarrhea and all that sort of stuff that happens when you're under a lot of stress. And so what they had us do was they taught us a 3-step system. Number one, every time you have a negative thought, the first thing you do is visualize a stop sign. Just close your eyes and just stop whatever the hell you're thinking of and just go stop. Like stop. Okay. Then you take a nice, slow, deep breath in for 3 and out for 3. Okay. And that oxygen immediately turns off the adrenaline of the negative thought. Okay, so that's important. That simple deep breath is the center for all of this. So stop sign, deep breath. And the third step is you do have to remind yourself it's a thought and it has no power. So what I say to myself is, oh my God, Jill, how arrogant can you possibly be to think that that you can predict the future? You're not God. For all you know, tomorrow can be a fantastic day. And so that's my reality check when I start catastrophizing. And so what they did is they taught us this 3-step method. And they said, now listen, this is our goal for the next week. All we're trying to do is reduce your adrenaline levels. So you got to be really persistent. So your first day, you're going to do this hundreds of times because you have no idea how often you have negative thoughts. And they were right. When I went home and I made a commitment to do this, because it made sense to me that I would be chemically sensitive to adrenaline, I did it like 100 times. I'm not lying. I was stunned when I really paid attention to my thoughts. I was scaring myself every other minute with a negative thought, like, oh my God, there's going to be a fire tomorrow, right? Which is what we're dealing with now. So I did it 100 times the first day. Maybe the next day I did it like 50 times. The day after that, I did it like 25 times. By the end of the week, I was only doing it once a day. And I was calm. For the first time in probably 20 years, I was actually calm. And it blew my mind. And so what I should have done, as soon as I mentioned fire, because that's a trigger for me right now, because we almost burned down last year, is it's like, okay, stop sign, deep breath. Oh my God, Jill, for all you know, tomorrow's going to be a great day. There won't be any fires at all. And even if there is a fire, the fire department is so much better prepared. The odds of it affecting you are 0. It's like giving myself a reality check there. So just understand that having really good anxiety management skills to get that anxiety management under control so that you're not intensifying the pain and overwhelming your body with adrenaline is vital. It's just absolutely vital. Okay? Does that make sense? So if you email me, Christine, my email address is icnetwork@mac, short for Macintosh computer, mac.com.
Yeah.
I will email you that magazine for free. Okay. And then I want you to read that article and then call me and let's chat about it. Let's see what you think. Okay. All right. Then I'm going to move on. And unless Christine, did you have any other questions?
No, the only thing I need to deal with, I guess, now is getting beyond I've tried the pelvic physio twice, and the 2 times, like, the pain was so intense that I didn't go back. And like you're saying, like, all those trigger spots came up and it was just like, no, I can't deal with this.
Okay. And so you have to deal with this.
Yeah,
you have,
I know.
Yeah. But hon, it begins with this. It begins with this. You've got to understand your anatomy so that as you're laying on the table and they're working on you, you can visualize what they're touching.
So I'm not so triggered about it.
I've gone through pelvic floor physical therapy 3 times now, and it has saved my butt each time. And now I'm much more aware of when I tighten my muscles. And I think as we get older, our muscles get a little bit weaker. Plus, we're sitting for longer periods of time and doing all sorts of stuff. So just communicate with her and say, listen, I kind of got scared when we did it. I found it quite painful. And normally when the physical therapist is doing it, they're watching your face. And they might be asking you, does it hurt? Does it hurt? And you'll be saying, you might not be, I don't talk much. I go into this really weird laughing zone when I have physical therapy. And if it hurts, I'm like, I'm very weird about it. So what my physical therapist does is she just looks at the expression on my face, because when it hurts, I don't know. She said I do something really, really weird with my face. So she said, I know exactly when it's hurting you. Like a grimace. It's like, oh, when she's doing it. But I can't, I kid you not. I laugh when it hurts. And so I'm really weird that way. But if you can just let them know, okay, it hurts there, back off a little bit. They should back off a little bit. Ask them if there are trigger points, if they're touching a trigger point. If you've got a tight trigger point, they can, with the help of a doctor, maybe inject that trigger point injection with an anesthetic so that they can work on it and you won't feel it. But it really begins with this, okay, hon? So give it a try. Go on back. And for me, so when I had my hysterectomy and had to do it, the first 2 appointments, again, I laughed when it was hurting. And so she's like, how are you? And I'm like, I'm laughing. I'm just so weird that way. It didn't really start hurting me badly until I walked out and I was walking across the parking lot to my car. And especially when I went to sit in my car, I burst into tears, drove home sobbing, got home, got in the recliner, grabbed a heating pad, and I laid there for 8 hours with my heating pad. I went back the next week and told her exactly what I did. She goes, okay, we're going to go slower. And we'll see how you do when you sit in the car. And so again, I'm laughing during the appointment. I go sit in the car. Same exact thing happens. I sit in the car. It hurts. I start bawling my eyes out, drive home. Instead of 8 hours, it was like 4 hours, heating pad. I go back. The third time, it didn't hurt. The third time when I went to sit in my car, I did not start crying.
Yeah, that's awesome.
Okay. And so, a little bit of pain, having a little bit of a muscle relaxant that you can use when you get home would be useful. Having a heating pad when you get home is useful. And if necessary, maybe even a little bit of Norco. I think I used a little bit of Norco the first time. But, the muscles respond beautifully to therapy. We just have to start working with them correctly. Okay?
Okay, thank you.
All right. All righty. Let's go to Lorraine. And then we've got Carissa and Karen. Lorraine, I can see you, Lorraine, so I know you're there. Can you unmute yourself? I don't know if I can unmute.
Oh,
there you go.
I was just thinking when you were talking about the pelvic floor therapy, I was thinking, analogizing it to a knee replacement and how everybody says that the physical therapy after you get a knee replacement is so excruciatingly painful that if you don't do it, your knee replacement will never work. Like, you have to do it. You have to push through the horrible pain.
Yeah.
Have you heard that before?
Oh, absolutely. And that the knee replacements require much more physical therapy than the hip replacement.
I don't know about the
the knee replacement is definitely the one where the physical therapy can be the most challenging. But that's a good way to think about it. But how are you today, hon? How is life?
I have to confess that due to my childhood, which we won't go into, I only have negative thoughts.
Mm-hmm.
I haven't had a positive thought, I don't think, maybe since when I passed the bar, when my son was born and everything was where it should be, fingers and toes and all that. I can think of maybe 5 times in my entire life that I had a positive thought. It's all negative. And of course, law school made it worse because they teach you the worst case scenario of what can happen.
Right.
You're trying to always think of catastrophes.
Right.
What can go wrong?
Right.
That's law school for you. So
right.
For me to all of a sudden now switch my personality at age 71, all of a sudden now I'm going to be a positive thinker. It just seems not doable. Oh, because my whole sense of humor is based on gallows humor and negative thinking.
Yeah, but I've asked a lot of doctors why. Because for those of you who know me, I am extremely optimistic. I mean, my magazine is called The Icy Optimist. If you've ever talked to me privately, I am always 100% optimistic. And yet I also struggle with negative thoughts, right? And I've asked doctors why that happens. And The basic like explanation is like the chemistry is easier. I don't have a better explanation for that. I think it's fascinating, but that the brain chemistry of a negative thought is a little bit easier than the brain chemistry of a positive thought.
Oh, is that right?
Yeah, yeah. And I don't remember who said that to me, but it was recent too, like in the last 5 years. So,
I just bought this book. I don't know if you can see it.
David Burns. Okay.
Have you heard of it?
I haven't heard of it.
It's a seminal work, national bestseller, more than 4 million copies in print. David D. Burns, MD. It's called Feeling Good, the New Mood Therapy. It finally took me this long to get this book.
So, okay. So what I did, the book I got, and let me see if I can, hold on. Is it up here? Where is it?
Uh-oh, I see a knee injury there.
Yeah, no, it's a ruptured disc that's affecting my knee.
Oh, no.
Yeah.
That must be painful.
As long as I wear my compression bandage, it's fine. But as soon as I take it off,
oh God,
it's ridiculous. But you know, it's life. All right, I can't find it. But anyway, so
I am gonna make an effort. I'm gonna read this book cover to cover.
Okay, but I don't think that's the first book you should start with. It starts with it starts with affirmations. You've got to have some things that you say to yourself every single day. You know, like if you look in my office, you can see I've got a sign that says love. I've got a sign behind me that says believe. I have got happy, positive things around me every day. And Norman Vincent Peale, when he wrote The Power of Positive Thinking back in the 1950s, said that if you dwell in the negative, you're teaching your brain only to be negative. But if you start dwelling in the positive, you're giving your brain something to look forward to. You're giving the brain something to focus on. And I really agree with that. And it was when I got that book when I was like 35, that was the other thing that really helped. So he emphasized affirmations and putting Post-its, you know, on your mirror when you look in the mirror for the first thing in the day. I can do all things through Christ who strengthens me. Insert your own religion, you know. So it can be
what if you're an atheist? That's my problem.
I can do all things because I'm a kick-ass broad.
Oh, okay. I can live with that one.
Okay.
Yeah.
Every day, in every way, my life is getting better.
Even though in my heart of, there's cognitive dissonance is ringing off the wall. Like nothing's getting better.
Well,
my best days have already passed.
Well, but you're not God. You can't predict the future. For all you know, tomorrow might be a fantastic new day filled with lots of new opportunities.
Well, today's a good day because I particularly like your what you had to say today.
And so good. Look at there. You just had a positive thought. Today is a really good day. So
very valuable lecture today.
So what he told us to do is he had a list of affirmations and then he said write them on a postcard. And so I got a little spiral postcard thing that I wrote every affirmation on, and I stuck it in my purse. And I was afraid to go to the doctor. I got to the point where I felt like every time I was going to the doctor, I was being hurt in some way, either physically or emotionally.
Well, that's because they do that.
Well, exactly. Yeah. And so I would have panic attacks before each appointment. And I was just like, I'm done. I don't want to live this way. I'm going to get help. Yeah. So I took my anxiety management class, and then I started doing my Norman Vincent Peale routine. So I have my little wire-bound Post-its, and I would go sit in the waiting room, and I just go through them, and I would just say them over and over and over again. I can do all things through Christ. Every day in every way, my life is getting better. That which is done for you, let it be done. That which you must do for yourself, do it. Be bold. My favorite one of all, be bold. And mighty forces shall come to thy aid, whatever they be, whatever your faith is, or even if you don't, just be bold.
Yeah, that sounds good. Be bold.
And you know, back when I was in my first job before I went to grad school, I worked for the feds. I worked for Social Security. I was a Social Security black lung specialist for a year before I went back to grad school.
Oh my God.
And I didn't do things by mail. I called people up. I was bold that way. And my rate was huge. My clearance rate was double or triple what my peers were doing. So much so that they got mad at me. My boss loved me. They told me to slow down, but it was just natural until I called the top secret phone line. I called the top secret phone line, and the guy goes, "Who are you? Where are you located? Who's your boss? Get him on the phone now." And I accidentally called the top secret line. Okay, but anyway, you got to be bold. It's okay to be bold. Listen, we don't want you to be a patient. We want you to be a responsible participant in your medical care.
Sounds like an Aaron Brockovich kind of a thing.
Exactly. Yeah. I mean, if you had another attorney say to you, "Oh, you are the most stupid attorney I've ever worked with. I will beat you like nothing." What are you going to do? You're going to go, "Oh yeah? You think so? Bring it, baby. Bring it. Bring it." And that's kind of like the attitude I want you to have with your IC. It's the same thing. It's a fighting spirit. Don't be a patient. Wait for somebody to come to you. You've got to go seek out the care you want, asking the right questions, and treating doctors as your peers. But also do it with a sense of confidence. I mean, here's the gift. We're older now. We know who we are. We're not 18-year-olds or 22-year-olds or 25-year-olds who aren't sure what they're supposed to do with our life. We have been, we're the coal that has become the diamond over the last 40 years. We're tough. We're strong. Embrace it. Use it to get yourself to the next stage that we want to get you to, because we want you to get better. Right?
Yeah, no. Great advice, affirmations. So maybe I'll look for another book. I'm not sure about Norman Vincent Peale because of the religious overtones.
Well, I mean, you can just you can use his. I don't use all of his affirmations. I use the ones that resonate with me. And you can just Google affirmations, and there are all sorts of. I mean, I just did 19 positive affirmations that will change the way you think. And,
that's nice. Yeah.
And what the research done by Harvard Medical School with chronic overlapping pain conditions clearly shows that positivity is an essential part. Let's see. I am love. I am purpose. I was made with divine intention. I mean,
that's good.
I don't sweat the small stuff. Like, there you go. I like that. Here's another one. I can, I will, end of story. I love that one.
End up.
I am adventurous. I overcome fears by following my dreams.
Those are all good.
I feed my spirit. I train my body. I focus my mind. It's my time. You know, I am in charge of how I feel, and today I am choosing happiness. You know, and you can be happy and still be in pain. That's okay. It's understanding that in the presence of anxiety, your brain is absolutely intensifying your pain, because your brain is paying attention to how you're feeling. And when you're anxious, your brain thinks that you're fighting for your life. It's just that animalistic. It's very primitive. It's a very primitive response. And so we really have to compensate for that in some way. I will not compare. Oh my God, this is great. I will not compare myself to strangers on the internet.
That's the worst. The worst is trolling the internet and seeing all the happy people. That's the worst.
Here's another one. I am choosing and not waiting to be chosen. I am choosing and not waiting to be chosen. Or I am enough. Or I am.
Well, I always say that I'm going to find my dream man who will have botched prostate cancer surgery and can't get an erection, and then we'll be the perfect couple.
I personally have said almost exactly the same thing. Perfect man for me is. Oh God, yeah. Yeah.
I thought I invented that joke.
Yeah. So if you got Post-its on your bathroom
Yeah.
mirror and on, man, girl, you got to dive into that because it's a habit. It's just a habit. You're stuck in the negative habit like me. And that's brain
it's been
function.
a long time. It's like 71 years of negativity. You know, my favorite saying used to be winning through negativity. That was my stand-up comedy routine.
Oh boy.
You know, I based my whole personality on that negative Jewish humor. You know what I mean?
Oh,
like
I do.
Yeah.
Yeah.
So I have to like remake my personality, which would take a lot of the humor away. But
but
I guess it's necessary.
I mean, you don't remake your personality. I mean, your personality is your personality. You are you. This is just about kind of refocusing your brain attention. It's very, and as an attorney, that's hard. And honestly, my job, it's hard because all day, every day I work with patients who are in pain, right?
Oh yeah.
But I've got really good self-defense mechanisms. And one of the things that I do that I don't hide from anybody is after particularly difficult days, I go shoot things on computer games because I need to get it out. I do. I did a sniper shot from 250 meters in Fortnite last week. They said it was an impossible shot. I am 61 years old and I play Fortnite.
It's supposed to be really great for hand-eye coordination. They recommend it for surgeons.
Well, it's
good.
And it's not bloody. It's just fun. It's just fun.
Yeah.
So you have to have a way to release the stress a little bit more. So anyway, listen, I would love to talk to you this week. If you want to talk a little bit please call me. I'd be more than happy to talk with you and maybe give you a few other ideas too. Okay, hon? But you are certainly not alone. And embrace the fact that you're a tough bitch like I am. I'm gonna embrace it now. I just, man, these wrinkles have been earned. No shame, no blame.
You don't have any wrinkles.
Oh,
no,
girl.
You don't. No one would know that you're 60. No one.
Well, blurring powder.
No.
All right. Well, listen, nice talking with you, Lorraine.
Yeah.
Please reach out to me. I'd love to talk with you more. Okay.
Okay.
Okay. Let's go to Karen. Karen, are you there?
Yeah, I'm here.
Hey, girl. How are you today?
I'm good, thank you.
What can I help you with?
I've been listening the whole time.
Okay.
Can you hear me?
I can hear you just fine. I was just wondering if you wanted to turn your camera on. If not, that's okay. You don't need to.
Not right now, if that's okay.
Not a problem. Not a problem at all.
Because you said earlier that this is going to be recorded or something like that.
Your voice. It's just people on Facebook and YouTube can hear your voice. They will never.
Okay.
They will. The video is not shared in any way.
Oh, the video's not shared,
No.
just the voice.
No, it's not set up to be shared. I don't even know how to share it.
Okay. All right. So, I've been trying to get an answer to my health issue for 1.5 years.
Okay.
So you use the 4 words: frequency, urgency, pressure, and pain.
Yes.
I definitely have frequency and pain.
Okay.
I guess pressure and urgency might be interrelated, but definitely frequency and pain.
Okay.
So
where is the pain?
the pain is in my pelvic area.
Okay. Is it centered or is it to the left or right of center?
It's centered.
Okay. Is it inside of your body or on your skin on the outside of your body?
It's inside my body.
Okay. Is it shallow or deep?
Oh, that's an interesting question.
Is it like by your urethra or is it like a couple inches deeper into your pelvis?
I don't know that. Sorry. I just know it's below my belly button.
Okay. Is it right below your belly button or is it down by your pubic hair and your pubic bone?
Well, sometimes when I try to touch my body, when I'm in the pain, I'm trying to touch it to see where it is exactly, but it hurts so much to even touch it. I just kind of wimp out.
So
Oh.
do you have, when you touch your skin even gently, does it hurt?
Yes. When I'm in a pain level of 7, 8, or 9 out of the 10, it definitely hurts. Definitely hurts.
Okay. How old are you?
65.
Okay, and when did this all begin for you?
January of last year.
Okay, so you were 64, January of last year. This was right before COVID, or perhaps right around when COVID started. Was there any event that you thought triggered your symptoms?
Not that I can recollect.
Okay, okay. Do you know, did your symptoms begin after, did they just begin suddenly, or did they begin gradually?
I just started getting some, I think at that time, I think I was dealing more with some frequent urination. And then I had some small pelvic pain. I was actually calling it my abdomen until I had an MRI test recently.
Okay.
And she told me it's not my abdomen. She said it's my pelvic area. So
Okay.
it started like in January of last year.
Okay.
And then I was motivated to I'm the type of person where I don't go to a doctor unless I'm in major pain. Okay.
Okay.
So anyway, so it would have been March of last year, November of last year, and April of this year that I saw a urologist.
Okay.
But the first person I actually saw was an OBGYN last year because in my 30s I had a myomectomy surgery.
Okay.
And so you know what that is?
Well, ovarian? Did you have an ovary removed?
No, I had a myomectomy surgery.
Oh, a myomectomy. No, I don't know what that is.
No, not myomectomy, a myomectomy.
Okay.
So I had uterine fibroids in my female area. Okay.
Okay.
So basically, I was in my 30s when that happened, and the number one motivator for me to get a myomectomy surgery, it's an abdominal surgery, is what it is.
Okay.
So they're taking out non-cancerous tumors that 99% of the time they're all non-cancerous, which they were. Okay?
Right.
But I was on a mission to keep my uterus because at that time I was hopeful to be married and have children.
Right.
Because most of the doctors, even at that time, 30, 35 years ago, wanted to give me a hysterectomy.
Right.
So I figured if there's Save the Whale campaigns, I was going to be on Save the Uterus campaign, especially in my 30s. Okay, so but basically I had frequent urination going on. So fast forward, I told you I'm 65 now. So now I'm dealing with this frequent urination thing, and I'm thinking, oh my gosh, did my fibroids grow back, or is it impacting, that area again? So I went back for an ultrasound with my OBGYN, and they said definitely some fibroids have grown back, but nothing to be worried about, nothing to concern myself with.
Okay.
So that was a year ago, January. And then he says, well, if you're experiencing some pain, go see a urologist. So I go to see a urologist, and then the urologist tells me, quote unquote, I have bladder inflammation.
Okay.
So he prescribes a drug, and then he sends me home and says, come back in a month and, I'll see how you're doing.
Okay.
So that was urologist number one, who gave me, I had 3 visits, March, November of 2020, and then April of this year.
Okay.
So with all 3 visits, it was the same diagnosis and it was the same thing, but he just sent me home 3 different times with 3 different prescriptions, excuse me, 2 different prescriptions. And then the one time he said I could just get an over-the-counter Tylenol or ibuprofen. Okay. So my philosophy when I deal with people, it's like 3 strikes, you're out, like a baseball game. So if I'm not feeling any difference, nothing's changing, then I stopped seeing that urologist. Okay. And then the office calls me back and they say, there's nothing else we can do for you because we only handle the bladder. You need to go see your internist. So I go back to my internist this year, and my internist, I think he's the one who prescribed, go get a CT scan.
Okay.
So I go get a CT, I go get an MRI, and then there was conflicting information with those results. Basically, they found first they said they found a mass on my ovary.
Okay.
Then they say that it was an enlarged uterine fibroid. I have an enlarged uterine fibroid uterus.
Okay.
Okay, so there's discrepancy there. So now they tell me to go see an OBGYN oncologist.
Okay.
And the very first thing the regular OBGYN says is, don't be worried. I'm not saying you have cancer, but this would be the next step.
Okay.
You know, so then I go see the OBGYN oncologist, and she said, there's really nothing there. Basically, just go to a urologist.
Okay. So I can see why you're frustrated, and you have to understand that before we can really talk about therapeutic options for you, we really have to understand anatomy. And so we've got two functional theories going on. Theory number one is that you have a fibroid tumor pushing on your bladder. And we had a research study presented last year or the year before, which showed that fibroid tumors pressing on the bladder absolutely can cause frequency urgency. And when that fibroid tumor is removed, the frequency urgency usually improves dramatically. And I can try to find that research study for you if you want to see that. So there is precedent for a fibroid tumor pushing on your bladder and causing the symptoms of frequency urgency, okay? But the other thing that really hasn't been discussed, which I think is critically important here, is genitourinary syndrome of menopause and estrogen atrophy. So at your age,
Can you just repeat that real quick? Because there was a lot of words, new words for me.
let me put it in chat here. Here, hold on a sec. I can put it.
I only got the word genital out of everything you just
So
said.
genito, not genital, GENITO. And then attached to that word is urinary, URINARY. So the genitourinary syndrome of menopause. And that's really the very first thing we're going to suspect in somebody who develops symptoms at your age is the fact that the bladder relies on estrogen to produce that nice thick coating of mucus. And without that mucus, your bladder it can't protect itself. It just doesn't have the ability to protect itself now. And it's much more vulnerable to irritation and infection. So if your vulva is dry and or your vagina is dry, then so is your urethra and so is your bladder. That is what happens. They all use that nice coating of estrogen to protect themselves, right?
Right.
So so those are the two. So I guess question number one is, does your pain get worse as your bladder fills with urine?
Does it get worse? Was that the question?
Yes. The fuller you get, the worse you feel?
Nope. I have no problem urinating.
Okay. So you have no change in your pain as your bladder is getting full or your bladder is emptying. There's no change in your pain.
Right.
Okay. So that rules out your bladder. Because if it were your bladder wall, you would have, if your bladder wall was wounded, you would have pain as your bladder fills with urine that is relieved by urination. So the fact that you don't have any changes in your pain as your bladder fills or releases, do you flare when you eat or drink something like coffee?
Yeah, I don't drink coffee. I'm not the typical American. I don't drink coffee. What triggers my body is sugar.
Okay.
Sugar.
Yeah. So sugar, that makes sense. That could mean that you could have a chronic fungal infection. Chronic fungal infections have been proven to be found in some patients with IC symptoms. So flaring with sugar is one of the rare types of flaring, but it's very real. It happens to people. I don't do well if I do a lot of sugar. I tend to keep my sugar and my white carbs very minimal. I do better with I don't eat white bread at all. I do Ezekiel bread when I eat, because if I eat white bread, I get very bloated and gassy. So anyway, I think I would have the gynecologist and or the urologist look at the quality and health of your skin, because they can see estrogen atrophy. Your skin gets, it changes shape, it gets thinner, and also you get some stripes in your vagina that is really clearly a sign that your skin is weakening. And so I would see what they say about the health of your skin. Does your urine ever feel hot when you're peeing? Like it's burning you?
No.
We call that urine burn. That's kind of a sign. Do you use any topical estrogen? Do you use anything?
Well, I do sometimes get a burning and itching sensation in my private area. So I think they gave me S-Trace for that.
Yes. And are you using the S-Trace?
I use it when I have the burning or the itching sensation. I don't use it all the time. Well,
that's the problem, is you're not using that correctly. S-Trace is not an anti-itch medication. S-Trace is a compounded estrogen, and it's meant to be used a couple of times a week over time. You don't normally stop and start it. You normally use it. The nice thing about topical estrogen is that it's considered remarkably safe. Your skin immediately starts to use that estrogen to produce mucus. And so we see visible changes in the health of the skin, improvements in the health of the skin very, very quickly with the onset of using estrogen. But at your age, you're not producing estrogen naturally, so your skin is dry. Clearly, they gave you S-Trace, so they know your skin is dry. You're just
they gave me that because of my burning and itching in my private area. My OBGYN gave me that.
Okay, right. But the burning and itching is caused because you don't have mucus, because you're dry.
Okay.
You know, your bladder, so you're a mucous membrane organ, which is your vulva, your vagina, your urethra, your bladder, and your mouth, are meant to be wet. There's a very thick coating of mucus. We call it the mighty mucus. And the purpose of the mucus is to protect the tissue. It doesn't let anything in urine through to irritate your skin. It doesn't let anything irritate your skin. And it also makes it hard for bacteria to infect you. There's a barrier. But at your age and at my age, we're not producing mucus. So our barrier is much, much thinner, if not in some cases, maybe even gone. And so what that means then is chemicals, laundry detergent that's left over in your underwear is going to hit your skin and irritate you. If you use fabric softener that leaves a scent in your skin, a scent in your underwear, that is immediately going to get onto that skin and irritate that skin. I flare if I use Tide. I will immediately have skin irritation and burning from Tide of any type.
What do you use for your detergent?
I use 7th generation Free and Clear. And I love it. I love it. And with my underwear, I always rinse it twice anyway. I always rinse twice. I want to get any chemical residue out. And ironically, this week, somebody had washed something in the washer before I did my underwear. And even though I had rinsed it twice, when I put it on, I immediately started burning. As soon as I sat down, I immediately had skin irritations. Like, nope, got to put it all back in the washer and wash it again and get all the chemicals out. Mini pads, if you wear a mini pad because you leak, mini pads can release, when they get wet, they release a chemical that can irritate your skin. So
I sometimes wear a mini pad, but I buy the unscented.
Yeah, but it's just not the unscented, it's the chemicals that they use to make them thin. You want to make sure you get an organic cotton mini pad. I used to wear Always, and Always pads are really notorious for causing more irritation of your skin down there. There's a certain type of Always pad that burned like hell when I used it. And so, your skin doesn't have any defenses down there. It can't protect itself. So any chemical that's down there is going to reach right into your skin and trigger the nerves right at your skin. That's going to cause the pain and the burning and all that stuff. So you really sound like a genitourinary syndrome of menopause patient. You sound like this is all being driven by dryness down there. And I would tell your urologist that, the pain doesn't change as your bladder fills. You're not worse when your bladder is getting full, nor are you better. And that kind of rules you out as a bladder wall injury patient.
Okay, so I want to let you finish talking because I'm going to learn from you. You finish talking, then I just want to give you a couple other data points.
Well, no, go ahead. I'm kind of done. Go ahead. Give me your data points. Okay,
so here's what I want to say is, first of all, thank you for your time and your expertise. I'm very appreciative because this has been a bad roller coaster ride for a year and a half, not getting a solid diagnosis.
Yeah.
And but I want you to make sure I'm clear on a point here, and that is when I have pelvic pain, okay?
Yeah.
I'm talking about I'm now at the level of 7 to 9 out of 10 level pain.
Yes.
I'm talking about I'm ready to go to the emergency room.
Okay.
And so I've been I've had all those other things we're talking about. The itching and it feels like my private area is on fire. That's going on. That I've been living with for a while. And sometimes I think it might just be inflammatory food. So I'm trying to watch my diet, inflammatory foods. And I could be wrong, but here's what I'm trying to say. What I'm dealing with, which is impacting my life, okay?
Okay.
That was impacting my life, but now I'm at a whole new level of a health condition impacting my life. And that is my pelvic pain. When I'm going to a 7 to 9 level out of a 10, I cannot function.
Okay, so
I have a job right now where I'm working remote. I could not even be working right now if I wasn't working remote. I don't have the energy. I don't know when this thing is going to trigger.
Okay. So hold on a second.
So can I just tell you real quick the bottom line? So the last urologist, I walked in the door telling him, quote unquote, I have pelvic pain. I walked out of the door. This was just within the last 2 weeks out of a year and a half, my second urologist, and he said, I have chronic pelvic pain. He didn't tell me anything new about what I already have. And he's the one who said, this is the only guy in the first year and a half who said I should go for a pelvic floor therapist.
Yeah. Yeah. Oh, you absolutely should have an examination by a pelvic floor therapist. We need to know at your level of pain, we need to do a proper and thorough diagnostic evaluation, and a pelvic floor assessment would be absolutely the right thing to do. But I want you to get back, so your pain is so severe you can't function. Does that mean that you can't walk? Or are you literally like laying on the floor in the fetal position when it's that bad?
I'm not fetal because that hurts because I'm crunching up my abdomen pelvic area.
Okay.
My position is on the bed or on the floor, laying horizontal. Well, first of all, I'm popping ibuprofen, and then after that, I'm laying horizontal and I'm literally using a heating pad.
Okay. Do you ever have pain that shoots down your leg?
Never on the leg. Nothing with the legs.
What makes the pain worse?
Sitting down will trigger my pain. If I'm sitting too long, that definitely triggers it because I'm sitting in front of the computer. I mean, I'm 65. I'm still working. I'm a corporate recruiter.
Okay. Okay. So sitting, how long does it take before the pain starts when you sit down?
It kind of varies from day to day, but the majority of the time it's kind of like towards the middle to the end of the day.
Okay.
So now I'm sitting for about 5 or 6 hours. I mean, I'm getting up for lunch and I'm getting up, a little bit of movement, but I'm working remotely. So I'm not like really walking or getting into the office I'm just kind of in my house.
Okay. Okay. So now, so is your pain by your rectum?
No.
So your pain is in front. Is your pain by your clitoris?
No.
Is your pain in your urethra? It's it can be a very sharp pain.
I don't know how to discern that. Okay, it's a sharp pain.
Okay.
A sharp. Yeah, I can tell you this. It's when I go to a 7, 8, or 9 level, I'm definitely experiencing sharp pain.
Is it pins and needles? Is it electrical? Do you feel like you're being shocked?
Wow, you're asking better questions than all the doctors I've met for the last year and a half. No, I'm serious, Jill.
Yeah, I know.
I've been seeing doctors for a year and a half, and none of them ask me these brilliant questions like you.
Okay, so is there any pins and needles or areas of numbness?
I can't really say numbness. It's just, I'm kind of call it more sharp pain because it's so painful that I'm ready to go to the emergency.
Okay, but we're still, okay, we're trying to differentiate between muscle pain and nerve pain. Okay, so nerve pain is electrical. It's pins and needles.
Okay.
And if you had pudendal neuralgia, IC subtype 4, you would have pain on sitting that would be relieved on standing.
Mm.
Do you ever feel a fluttering, a movement when you sit for a long period of time? Like you're sitting on a cell phone on vibration?
No.
So you don't
not the fluttering, more of a intense, constant, sharper pain.
Okay. What makes the pain better?
Number one.
Yeah.
Number one. Are you ready?
I'm ready.
A heating pad.
Okay.
I can pop all the ibuprofen in the world, and I mean, he upped the dose, and then he says, I call him back. I go, I'm still got too much pain. It's not helping. He goes, well, the next step is going to be a narcotic. And I'm kind of anti-drugs. I just want to tell you, my philosophy is more alternative medicine, functional medicine. It's not really Western medicine. I still believe in Western medicine, but if I can avoid drugs, I will avoid drugs. I'm not the typical American who loves pushing all these drugs.
So have you ever tried a muscle relaxant like Flexeril or Baclofen?
No, I didn't even know what those were.
Okay, so there are two different types of muscles in your pelvis. Your bladder itself is a smooth muscle. So if you were having bladder spasms, we would use a smooth muscle relaxant like ditropan or Detrol. The pelvic floor, these muscles are skeletal muscles. And so skeletal muscles require a skeletal muscle relaxant, and that's going to be Flexeril, which can be a little sedating, so you only take that at night, or Baclofen, which is...
Can you spell those for me, please?
Yeah, Flex, Flexeril.
Okay.
Or Baclofen, B as in boy, A, C as in Charlie,
yeah.
L-O, F as in Frank, E-N, or Valium. And in fact, a vaginal Valium suppository that you would put right into your vagina when it happens could be remarkably helpful at stopping that spasm. So, that
one scares me because
why?
Before I had that last one scares me because before I had this pelvic pain.
Yeah.
This is a few years ago, but when I was dealing with the burning and the itching in my private area, she gave me something. I don't remember what it was, and I thought I just wanted to scream. It was a vaginal, plastic tubey thing going up my vagina with the medicine.
Okay.
And I thought I was going to scream. I was going to scream.
Okay, but you know why you wanted to scream? Because your skin was so bad. Your skin, that's the thing is when you use topical estrogen, the first couple of times, it's going to feel very, very hot, like it's burning you. And it's not burning you. That's a direct reflection of the quality and health of your skin. That means your skin's messed up. And so when I was 51 and I started having this, he gave me estrogen. It was very hot at first. It was very uncomfortable for about an hour, 30 minutes or an hour. And then every subsequent time that I used it, the heat got better and better. And now it's just a little warm puff of air unless I forget to use it for a week, and then it will burn again a little bit. So that heat is a direct reflection of the quality and health of your skin. So, and some women do that. Some women they're afraid of that and they walk away from it. And unfortunately, that's the worst thing you can do because your skin's just going to get drier and drier and drier. Topical estrogen works. We do better with a preservative-free topical estrogen. Like I get a preservative-free estrogen from the Women's International Pharmacy that I use, and it doesn't hurt at all. You know, unless I forget, like if I forget to use it for 2 weeks, it will feel warm for a few seconds, and that's just my reminder to be more consistent, because I tend to be a little passive aggressive with my estrogen cream.
So what is the topical estrogen that you're using?
Estradiol.
How do you spell that?
Estradiol. Estradiol.
And you said you get, is that,
it's not over the counter. It's a prescription. And you just need to have them look at your skin again and get some eyeballs on your vulva to see where you are. Listen, you and I are going to be struggling with estrogen loss for the rest of our lives. It changes the things. It changes our skin. And the best thing we can do for those of us who have urinary syndromes from the loss of estrogen is to be consistent and use that little bit of topical estrogen. Topical estrogen is considered remarkably safe because it stays in the tissue. It is not distributed through the body to any great degree. So, and if you don't do it, you're going to get drier and drier and drier. And I've worked with some women in their 80s who literally their little vulvas are like dry potato chips, and they're in agony. I mean, I'm not lying. They're in agony. And so you and I and everybody watching and listening, listen, we have to be attentive to our skin health down there. When things, think about how painful dry mouth is. When you've got dry mouth, you drink water. Well, dry bladder, dry urethra, dry vulva is painful. It's uncomfortable. And so I suspect that you are dealing with a pretty significant level of estrogen atrophy, because they've already identified it, and that's what's causing your burning and your pain down there. But I wanted to show you one other thing, because I'm still not convinced that the fibroid is not playing a role in this too, because your pain level is over the top. But listen, the vulva and the urethra and the bladder can hurt like hell because they're dry. So theory number one is estrogen atrophy, and I'm sure that's playing a role. But I want you to look at this too. I want to show you something. So look, here's your pelvic cavity, right?
Right.
And I want you to see, so I'm going to put a vagina and a uterus in here. Okay. So now we have the vagina and the uterus taking a sizable amount of space. And now I'm going to, so this is your vagina. This is your uterus. Hi, Gwen. I'll be with you in just a minute. And now look, I'm going to put the bladder in, right?
Right.
So if you have a fibroid mass pushing down onto your bladder, that also, I mean, I want you to see the proximity here. They're really, really, really close. And so I think I would want to get a second opinion about that fibroid too. If I were to guess, I think that you've got severe estrogen atrophy combined potentially with a fibroid pushing on your bladder. Both of these are extremely treatable. You could be a new woman in a month just with the proper estrogen therapy.
With the proper estrogen therapy?
Yeah, with a proper estrogen therapy.
Proper estrogen therapy.
Just a topical estrogen.
Well, what should I buy or use? Well,
you have to have a doctor look at your skin, because they've got to decide how severe it is and how often you should use it.
So that means I'm going to a skin doctor?
No, you're going back to your gynecologist. And just let them look at your skin. Google genitourinary syndrome of menopause.
Google
genitourinary syndrome of menopause. Your textbook GSM combined.
Wait. Genital urinary syndrome, right?
Yes.
Okay, but the genital, you said
genitourinary syndrome of menopause.
Okay, yeah, that's what you told me earlier. So just Google that.
Yeah, and look at the symptoms, hon. I think your textbook GSM, but I think your fibroid is interesting. I wouldn't expect GSM can be agonizing. You can be literally need pain medicine with a very, very, very dry vulva and vagina and urethra. But, and you said burning, you used the word burning once to describe your pain.
Down in my private area, intermittently, it will literally feel like my private area is on fire and or I am itching.
Right. So that speaks to your skin. That speaks to your skin, and that speaks to estrogen atrophy.
That speaks to the genitourinary syndrome?
Yep, completely.
And also you said what else did you say? You said the atrophy or something?
Well, it's the same thing. They used to call it estrogen atrophy, and that is when skin atrophies due to the loss of estrogen. The skin changes, skin breaks down, it gets drier. And then they started using this new word, genitourinary syndrome of menopause, 2 years ago. Same thing. They're the same exact thing. And there's also a book you should think about getting.
Oh my God.
No, this is what's exciting, hun. This is all treatable. I'm not scared for you at all. You just haven't done the right therapies. There's nothing that you're saying to me that worries me. It just sounds like a very simple case of GSM. Your nerves are massively irritated because your skin is dry. But we've got this other external thing about the fibroid tumor potentially pushing on you. This book, The Menopause Manifesto, just came out 2 weeks ago.
Okay, I can read the title, but I can't see the author's name. Let me just take a picture of it. Okay, Dr. Jen Gunter. Okay,
yes.
Thank you.
The reality, as she says, this is reverse puberty in action. Think about how crazy teenagers are when they're going through puberty as all their hormones ramp up. Well, it's crazy for us as our hormones ramp down. And the consequences of that on our skin is real. And the first line in her book is hysterical. If menopause were on Yelp, it would have 1 star. It would have 1 star. And it would be, this establishment has temperature control issues, drenching heat followed by terrible chills, defies the laws of thermodynamics, would not recommend. The next review is awful, awful, awful. Bleeding was scheduled, but was rebooked without notification. So arrived 3 weeks later than expected while I was in an Uber and I flooded the car. The driver gave me a terrible review. And the third one is the sex was dry. She says, and it's no surprise. Most women have no idea what to expect when they are no longer expecting a period. And it's uniquely awful and disempowering to not understand what is happening to your body. Menopause is like being sent on a canoe trip with no guidebook and only a vague idea of where you are headed. Although the expectation is it's awful, there will be no advice on how to get there or how to manage any of the obstacles. That is, if any exist. Who knows? Have fun figuring it out. Good times. Oh, and don't write. No one wants to hear about your journey or what it's like when you arrive. Fear, check. Uncertainty, check. Medical ramifications, check. Unpleasant symptoms, check. Societal irrelevance, check. No wonder menopause receives such awful reviews. The culture of silence about menopause in our patriarchal society is not something to behold. Menopause doesn't even rate the shame that society gives to the vulva and vagina. Apparently, there's nothing of lower value than an aging woman's body, and many in our society treat menopause not as a phase of life, but rather as a phase of death. And anyway, it just, man, let me tell you, this woman is amazing. Women tell me that menopause is lonely. There are no stories or cultures. So there's no whisper network to take up the slack from medicine. There's nothing to comfort. This book will give you comfort, my dear. Get it. It's so good. And it's on Amazon right now. Absolutely wonderful. Okay?
Okay, the Menopause Manifesto. Okay, so you're saying big picture. But where's the itching and the dryness and the private area and the burning, that's what you're calling. Are you using the acronym GSM?
Yes.
Okay, I just want to make sure I'm using. But the thing is that what about that pelvic pain? If I'm dealing with 7, 8, or 9, where's that coming from?
Well, because you need estrogen in your urethra and you need estrogen in your bladder. They're all getting dry. That's why when you read about genitourinary syndrome of menopause, you will see the bladder symptoms are common, specifically due to the loss of estrogen. And when you give that skin estrogen, the skin starts to heal and it's not vulnerable anymore. And the symptoms improve dramatically.
Okay, but that's in my private area, but that's not really my pelvis.
Yes, it is in your pelvis because your bladder is inside your pelvis. That's why I was hitting you so hard about location. Your bladder, look, here's your centered body. So here's your pubic bone. Here's your bladder. Your bladder is sticking out right above your pubic bone. That is inside your body. That can cause pelvic pain. So it can.
Oh, and then if I'm understanding you correctly, because of the dryness in the bladder, that might be having an impact on the pain in the pelvis.
But your bladder is in your pelvis. Bladder pain is pelvic pain. But there are lots of structures in your pelvis. You have a uterus in your pelvis, right? But you also have a lot of muscles and nerves in your pelvis. And so going to a pelvic floor physical therapist and having a pelvic floor examination to see if you have any issues with your muscles would be a very smart thing to do. So any of these can cause pelvic pain.
What do you do when you're at a pain level of 7, 8, or 9, and then you got to go see that pelvic therapist? I mean,
it's the perfect time to go. That's when you want to go, so that when it hurts.
So in other words, when you have the pain, they can maybe discern it even better what's going on.
Exactly. So you can have a bladder wall deficiency from estrogen atrophy. You can have something pushing on your bladder like a fibroid, or you can certainly have something going on with your muscles. That's possible. And the longer, they call sitting the new smoking. The longer you sit, the weaker your muscles get. So it may be that your muscles are just now kind of getting weaker and more vulnerable, and they might be creating trigger points, and who knows? We're guessing right now, and you deserve more than a guess. You deserve the facts. And so I see at least 2 appointments for you, to a gynecologist to have them look at your skin and to have them reassess a fibroid. And then a pelvic floor physical therapist to check your muscles perfectly would be reasonable. And as Lisa says here on YouTube, one of the things that can be remarkably helpful for skin pain, external pain, is coconut oil. If that skin, anywhere you have mucous membranes, it's meant to be moist, but it's not water-based. You need something thicker than that. And coconut oil is a perfect option to put on your vulva and on your labia. Some people use it for sex to make it more comfortable there. So the next time you have itching, you could try putting some coconut oil on there, or use coconut oil once a day, just to try to give that skin a little bit of moisture.
Okay, so with the estrace or without the estrace?
No, well, the estrace you don't use every day unless you're really severe. But the coconut oil, you don't use internally, you use externally. So if you're dealing with a lot of irritation on your vulva, on the outside, external pain, then giving that skin a little bit of oil to protect it might be very helpful. So coconut oil is a mainstay for us. It's a mainstay. Coconut oil or V-Magic. I have some V-Magic. Where is it? I had some here. Where is it? I don't see it. That's not it. Well, anyway, we sell it. V-Magic is a olive oil, avocado oil, sea buckthorn oil that also very closely mimics the natural oil of your skin. So quite a few women use V-Magic and they love it, or coconut oil and they love it. Okay.
Okay, but that's not going to help with when I have itching. Sometimes
Yeah,
I
it
have
could.
itching.
It could help with the itching.
Okay.
Totally. Yeah.
The itching could be from, so think about dry mouth. When you get a dry mouth, right? It's incredibly uncomfortable. And yet when you swirl water on it and you give that skin a little bit of moisture, it gets better almost immediately, but then it gets dry again 5 minutes later. The same principle applies to your skin down there. When it's dry, it's irritated as hell. And your skin doesn't have, at your age, you don't have a lot of estrogen. Your skin's ability to protect itself is now very compromised. It could be something as simple as your laundry detergent leaving a chemical in your underwear that is now penetrating down into this more vulnerable skin. Chemicals.
Can I say something?
Yeah, please, Gwen, go for it.
I have a lot of what she's talking about, and I'm very sensitive. I'm also very Norwegian.
Yeah,
Very Norwegian. I got my hair dyed, okay?
there you go.
But I don't know if this, I don't know how to use
I
this.
can see it. Replens.
Okay, the Replens, it's the external gel.
Okay.
And I get that at Target. I can't do the V one you're talking about.
Okay.
Because it's got something in it that I'm just sensitive to. And then when I go to the pelvic floor therapist, which I'm starting up again on the 24th, she uses the slippery stuff
Nice.
instead of like Astroglide or the coconut or olive oil because I'm sensitive.
Okay.
And this doesn't make me sting or burn. And I got this on Amazon for like, I think $10 and it's huge.
So, I mean, I see the name slippery stuff, but that's all I could read was slippery stuff. I don't know.
Yeah, that's all it's called. It's like a personal lubricant gel. I don't know if I can get it. Hold on.
So that helps with the PT therapist.
Yes. Well, they would.
Well, that's because they have to put their hands inside you or your fingers. And it would be like instead of Astroglide.
Yeah.
It's a different ingredient. It's very water-based, very mild.
Yeah.
And I use it with my tool. The one that you're talking about.
Yeah, the one. So I use
wand.
I use KY myself.
Yeah, I can't use KY. There's an ingredient in it. And so she suggested this one.
Yeah. So there's lots
I'm
of
fine with it.
So
Yeah.
there's lots of different lubricants that can help
Yeah.
anytime you have to manipulate that tissue. But
Yeah.
the more important thing that she showed you was the Replens,
Right.
external comfort gel.
And they have an internal one too.
Yes. Yeah.
But I got this at Target and I think it was like $25. It's really little, but it lasts a really long time. I just
So
use
that's
like
for-
the pea size.
Is that for the
Oh.
dryness on the exterior of my
yeah.
private area?
Yes.
For me, that's what I use. Because I'm sensitive to the estrogen too. So this has been all I can tolerate at this point.
Can you use coconut oil, or does coconut oil bother you?
You know, I have a mast cell disorder, so it depends on what day it is.
Okay. Okay.
Usually I've been sticking with the Replens.
Okay.
And so far so good. I don't use it every day, like you said. I just use it kind of when I have a flare.
Okay. When your skin starts screaming at you. And hey, Gwen, when your pain is the absolute worst.
Ugh, which has been a lot lately.
Yeah. I mean, the worst pain I ever had in my bladder was from a fungal infection. I had candida. And
now I did the DNA testing and they said it came, well, they didn't even know how to really read it, but
yeah.
I read it and it said I had no candida in there and I thought for sure it would.
Yeah.
But I tried to go see a new guy yesterday and it was a nightmare. I can't seem to find a good person out here. I've seen 4 different ones and none of them have even done the cysto yet. And again, I went in there to a new guy and, you know, he's like, so what do you want me to do? Like, okay, I'm going home.
Yeah. Yeah. Yeah.
But my problem is no matter what I eat, I have problems.
Yeah.
And I haven't gotten that bad until probably the last few years. I got diagnosed with MS in 16.
Okay.
And now it's gotten really, really bad. But I've had IC since I was probably 18 years old.
Ye-
You know, so yeah, I had a long time there for years. I didn't have a problem
Right.
at all. But now, whenever I can't even eat, I've dumped like 60 pounds. I mean, I'm really struggling. I cry all the time because it's like, I don't know what to eat anymore.
Yeah.
you know,
Yeah.
and
Okay.
I know it's the pelvic wall. I'm sure of it.
Well, again, estrogen atrophy plays a huge role in the sensitivity of the
know.
bladder. And for those patients who, let's say they get their symptoms controlled in their 40s and their 50s, and all of a sudden in their
Yep.
60s, it starts right back up. That really
Yep.
just means potentially that that bladder has hit that tipping point of losing and so much estrogen that it is now much more vulnerable. It's unusual though for you that so many foods are bothering you.
I'm now being considered a medical mystery.
Hmm.
I've gone through a lot of doctors.
So-
immunologists, gynecologists, dietitians, and I used to be able to eat anything. And I'd say I've had a lot of trauma in my body.
yeah.
And so now and I had a hysterectomy when I was in my late 20s, and I never really had a problem. I was always on estrogen. It wasn't until I went and saw a naturopathic and she took me off the chemical one and tried to put me on the regular one. My body just said, forget it. And now I can't tolerate anything, it seems like. And I'm scared because I don't know. I feel like I'm dying. I really do. I feel like I'm dying. And I tell my doctors that, and I've got, like you said, other problems now. I've got so many different problems: heart, kidney, bladder. Bladder seems to be the one that's irritating me the most, though. And so I'm a medical mystery, and the majority of my doctors are telling me, you just got too much to deal with. I don't know. I can't help you. And that's what I'm hearing now. And I was really hoping this new guy I was going to see, because this guy and the guy I saw before were supposed to be they are the chief urologist at the hospitals here in Phoenix, Arizona.
Yeah.
The only reason, and the only reason I didn't get the cysto done with the last guy is because his office kept canceling on me.
Right.
I didn't cancel. I was ready. I mean, I'm scared to do it, but I was like, okay, get my big girl pants on, and I'm going to do this. I just got to find out what the heck is going on,
So I think it's very, very useful and important to break this into small, manageable steps. We can't assume that every condition is related to every condition.
Thank you.
Okay.
And that's what I try to say to them. I had to several times bring back the doctor and say, listen, my main symptom is, it's not all the time, but I can't get my pee to start. And my bladder will get full. So they threw me some catheters because I know how to do it,
Okay.
But that's not solving the problem.
But what did you had a pelvic floor assessment?
I go in on the 24th to see the girl again. I went before I had my MS. I was seeing her.
Okay.
And
so
I kind of got better a little bit.
Okay. So when you first saw her and she did your first pelvic floor assessment, what did she find?
She told me that the muscles very deep inside towards the back wall were just completely trashed. Now, I've watched you for years, and I know I feel like a Xerox of you, okay?
Yeah.
I have the right side hip piriformis issue going on.
Right.
I've got body burning. I mean, nerve damage like you can't even believe. And they just want to throw it as, oh, it's the MS now. And I'm like, no.
Well, I think
it's not all just MS, okay?
Yeah. Okay. So look, you can see with my finger, I have to stretch all the way up to get to the muscle that she's talking about.
Now, is that the muscle that you say also bothers you with your right hip? Okay.
Yeah, but it's my it's my left side, not my right side.
It's the piriformis.
Yes, it's the piriformis.
But I'm also having issues with the pudendal nerve. I got stuck in a car just before COVID,
Yeah.
and my bladder got really full.
Yeah.
And that's what actually set off this domino effect with me right now.
Mm-hmm.
Is I ended up developing, I couldn't urinate once I got home.
Mm-hmm. Mm-hmm.
And I didn't have any catheters at the time. And then I ended up getting a arousal problem.
Mm-hmm. Mm-hmm.
And I go see my gynecologist and he freaking laughs at me. Okay. And I'm just like, okay, that didn't make me feel very good.
So this is very common. The worst thing you can do to a hollow organ is stretch it over time.
Yeah.
And so when you held when you had no choice, your bladder got very, very full. And we've had bladders rupture. We've had bladders actually rupture in cars.
I was going to ask you about that too, because the first guy I was going to go see, I asked him, can my bladder explode? And he goes, oh no.
Oh
But
no.
This last guy I saw yesterday said, oh, absolutely.
Oh yeah. No, the bladder can rupture. If you have a full bladder and you're hit with a soccer ball in your pelvis, that will rupture your bladder. That's happened before. So the challenge here is you sustained a bladder injury that was very painful, and your muscle
over many years.
Right, and your muscles got very, very tight in a guarding reflex to protect you from the pain. So the reason the likely possible reason why you couldn't pee when you got home was because your muscles were locked down.
It was a muscle spasm, definitely.
So to me,
vaginal Valium.
Yeah.
And sometimes that will help.
Exactly. So the pelvic floor physical therapy right now is going to be your single most important appointment.
Okay.
Let's see where your muscles are. And you know, you and I were both Norwegian. I am like 98% Norwegian Swedish and 2% Eastern Russian, something like that.
Right.
And so the odds are you have the same central sensitization that I do.
Right.
Okay. And so that
I do, because I've watched you and I'm like, God, I'm just like her. Exactly like her.
So that's the genetics. That's not a disease. That's just
can't help it.
How we're wired. Our nerves are more sensitive. And so we have to live our lives with the understanding that we have to protect those, which is why we don't drink coffee or neurostimulants or eat chocolate, because those are all neurostimulants. The challenge here now is that
I need to eat.
Yeah.
I can't eat. I'm afraid to eat.
Well, you shouldn't be afraid to eat. There are foods that your body will thrive on. We just have to figure out what they are.
The only thing I can eat that doesn't affect me is like zucchini.
Good.
Egg whites.
Okay.
I mean, I showed my doctor and he's like, you're not even getting 500 calories a day.
What
and
about,
I can't help it.
Okay, so can you eat rice?
I can eat a little bit of brown rice.
Okay. So you have a histamine. See, I can't eat brown rice. I have to eat white rice. I eat jasmine rice.
I can't eat white rice because it's bleached. And the bleach, I guess, is what irritated my bladder.
I don't
like avocados, almonds.
Wait.
Pears,
can you eat
apples.
Wait. Can you eat avocados or not?
I can eat a little tiny bit, but I'll feel it in I had a half of one and I can feel it already. It doesn't put me down unless I have a lot of it. Like
so you've been diagnosed with a mast cell disorder, correct?
They think I have a mast cell disorder. So my numbers are right on the edge.
So
on the edge.
That's something that you have that I don't have at this point in time.
Right.
But I will tell you, my body absolutely loved using an antihistamine.
Now, which one did you like to use? Because Benadryl just kicks my butt.
Oh, I can't do Benadryl. No, my heart races. I did visceral, also known as hydroxyzine.
Now, I have some visceral, but I didn't know you could do that for an allergy.
Oh yeah, it's an antihistamine.
Really?
Yeah, it's an antihistamine.
Okay, I have some of that.
So
that doesn't make you tired?
No, I only used it at night, and I used a very, very small amount. Okay. You take it around dinner time, and usually, I mean, it's a little tiny bit harder to wake up, but once you're up, usually fine. There's not usually residual drowsiness. At least I didn't experience that. It made me a little bit more heat vulnerable, but
Yeah, it's 116 today.
yeah, yeah.
I'm inside. I'm like, forget it.
So I just have to wonder if using an antihistamine will make you a little bit more tolerant of some foods.
I really do need to try it. I've kind of since the Benadryl, and I did try another one. It wasn't Allegra, it was Zyrtec, I think it was. I couldn't tolerate that one at all.
I think
It made me feel really strange, and it made my bones hurt. I don't know what that was all about.
Well,
but
we're just sensitive, you know. Half of the
I'm
things
sensitive.
that
You look at me wrong, and I break out.
I hear you. I totally hear you.
But like,
Well,
I'm like you, I can't do oatmeal either.
no, I can't do oatmeal,
Quinoa,
but
I used to. But the thing that's weird, I used to be able to eat quinoa. I used to be able to eat rice. I used to be able to. I cut all wheat out of my diet when I
yeah.
got MS, and I haven't had a relapse, really a big relapse since then, thank God. But it's the bladder thing, and then I got traumatized again. I got a severe 2nd-degree burn on my lower half down there. Luckily, it didn't go into the vulva area, but it hit on the outside of it
Yeah.
because it was hot water and it fell on me.
Uh-huh.
And ever since that happened, I've been nonstop having problems with my bladder.
Well, I think your nerves
The nerve damage, because I clenched and I fell back into the wall.
Yeah.
I mean, I know I'm like you, I agree. I believe probably 80% of my problem is muscle spasms and just trauma.
Yeah.
From falling and
nerve
falling off of bikes
and nerve sensitivity. Well, I think that
well, thank you for talking to me. I appreciate it.
But you deserve more than a guess, and you know all we're doing is guessing now. We need some facts.
Well, I know, and I'm trying to get a doctor that'll actually, you know, the thing is this new guy looks at my records, and I was diagnosed 40 years ago.
Yeah, but what do I always say? Do not walk in.
They didn't look.
I know.
Like, well, so what do you want me to do? Do you want me to look?
Okay.
So you're a freaking doctor. You're telling me that.
But remember, what do I always say? Don't walk into a new doctor and say you have IC.
I didn't. I did not say a word.
Okay.
He looked at my record.
So you need to be more.
Because my primary doctor stuck it on.
Okay, but you need to be more directive in those appointments. You need to go in and say, listen, I have a complex history. I am here because I want you to study my pelvis to help me figure out why I have this symptom. Yes, I have central sensitization. Yes, I had a pudendal neuralgia and PGAD, but that's fine now. Clearly, I have a long-term issue with my muscles, and we're working on that now. I'm going to the physical therapist now, but I want to know if there's anything else in my pelvis that could be contributing to this pain. As an example, if you look at the last blog I just did on my website, I talk about posterior phonic syndrome. I had never heard of that before. This is a woman with very severe symptoms. She had pain and she had a massive prolapse that was all due to a torn ligament.
And I always wondered about something like that because I'm retired military, Navy, and they did a botched hemorrhoidectomy on me when I was in my late 20s. And I never recovered from that thing. I mean, it was years. And for years, doctors say there's no connection. They look in my butt. There's nothing there. You're fine. And I'm like, no, you don't understand. And now getting that book I bought, and now they're all kind of realizing it's all there. Yeah. So now I really believe I never have recovered from that.
You need to get
that book.
Okay. And
I love that book. And I tried to take it to my doctor and he just kind of like shrugged his shoulders at me and like, oh, that's a nice book.
Well, I mean, again, your case is complex. It's happened over time. There's not going to be a single doctor who's going to figure it out.
Well, I try to keep it simple, but I don't know where to keep it simple at. You know,
well, but you can't expect any doctor to make it go away in one visit.
No, I don't expect that. I'd like to get my cystoscopy done.
And I would do it. And if I were to guess,
getting them to do it though.
If I were,
it's like crazy. I'm so sorry.
But if I were to guess,
I have to call you and tell you the
Yeah.
nightmare I just got over this last month and a half.
if I were to guess, I would bet your bladder's probably healthy. I don't know.
I would probably guess it's got inflammation, but it's healthy.
I don't know. I none of us know. And that's a very, very important I think having an in-office
Well,
cysto.
the thing is the guy I saw before then, this
Yeah.
last one, he's like, I think you might have Hunter's lesion because I have blood in my urine.
Well, so
I'm like, hello, let's get this done. And they canceled on me twice.
well,
I'm
COVID,
like, okay, I gotta go somewhere else. Okay,
Yeah.
I gotta get this done.
COVID has messed everything up.
It really
COVID has messed
But
everything
a
up.
lot of this was before COVID, though.
Yeah. Well, listen,
So
hon, why don't you call me this week? We
I
can
will.
talk a little bit more,
Next
okay?
week I'll give you a call.
Okay, that sounds good. You got Mayo Clinic down there. We've got a couple of other doctors. And I do have this new pelvic pain database of doctors I can look up for you, too.
Well,
But-
I think I asked you a few weeks ago, and there wasn't anyone out here. But I'm curious. I was looking at your IC 101. I missed last week. What is that?
That's our new book. It's the
nice.
a new book. We've been working on it for 2 years. IC 101. It's not just a bladder disease, and this is about
How is that compared to the one you just lifted up that I have?
well, because
What's the difference between the two?
well, this is just musculoskeletal.
Oh, okay, got it.
Okay. Whereas this talks about everything. This talks about
Oh,
all
okay.
the other interests. Plus, it has a huge section on diet, a huge section. I mean, it's very, very diverse. If you go on to our
Nice.
website, I've got the table of contents in
Oh,
the description so
okay.
you can see. So anyway, listen, guys, we're running long, so I'm going to have to shut down Zoom.
Okay, are you still on the other one though?
I'm still on Facebook and YouTube. We still have a
See you
couple.
over there.
Yeah. All right, Karen. Thank you, hon. Thank you, Lorraine. I'll see you
All right,
guys
thank you.
later.
I hope you get lady better the
Thanks
woman
a
that
lot.
was talking before.
Okay, thank you for your time, Jill.
You're welcome. Bye-bye now.
All right, thanks. Bye.
All right. The Zoom meeting has been shut down. All right. Let's come back here and all right. Hold on a sec. All right, guys. So you know what? Listen, that was such an interesting case for us. And I mean, the three different patients presenting in very, very different ways. And what makes Gwen's story so important, there are a couple of things that really pop out about her story. Number one, when I started this meeting, it's like talking to IC patients is kind of like trying to get water out of a desert. The devil is in the details here. And often it's the little tiny symptom, the little weird, unusual event that happens early on that kind of creates that foundation for trauma. So what was one of the last things she said is she had a botched hemorrhoid surgery when she was in her 20s. And what do we know about the pelvic floor is that pelvic trauma, especially recurring trauma over time, creates a history and pattern of long-term pelvic floor dysfunction. The same sense, she also has pudendal neuralgia, which is usually caused by tight muscles pushing on nerves. Plus, she had PGAD, which is where you feel this painful arousal sensation, which is from pelvic floor muscles squeezing a nerve. And so, yeah, but again, at the other time, we also have to consider age. Aging matters. The skin becomes more vulnerable as we get older. But if I were to bet, my bet is that, and Gwen, I don't know if you're watching, if you're on Facebook and YouTube, the question that I didn't get to ask you, that's really an important question, is what was causing the hemorrhoids? Hemorrhoids are caused by straining, right? Oh, there you are. So to me, Gwen, one of the more interesting things, again, is your hemorrhoid surgery. You were in the Navy at that time. Navy chow, not so good. I come from a Navy family. Plus, you're under strain where you're not necessarily able to access a restroom when you need to. So and also, as she said, very large babies. She also had very large babies. So I think you're kind of one of those early trauma patients or repetitive trauma. The first trauma might not have been so bad. Maybe you fell on your tailbone when you were a teenager or something. But then we have the hemorrhoid surgery, which, and for anybody who's watching, hemorrhoid surgery is one of the most painful surgeries you can have. You believe me, you have a vested interest in eating fiber, because going for hemorrhoid surgery can be remarkably painful as that tissue heals. So here you had that, which is, we're assuming here that you were constipated and you were straining, and that's what caused that. So the question is, why were you constipated? Could be related to the food that you had in the Navy, or it could have been related to dehydration. It could have been related to restroom access, or it could have been related to just tight muscles. One of the dominant symptoms of tight pelvic floor muscles is constipation. So you may have had a pelvic trauma early that began this entire foundation. Then you had another trauma, the hemorrhoid surgery. Then you had 2 more traumas, very large babies. And there you go. So what we have to do, what you've got to do, is we've got to get in there and figure out what's going on with those muscles. You're a complex case, and for everybody watching, you can see the complexity here. But the devil here is in not focusing on the bladder. She's being smart. She's going to let somebody look in her bladder. I say go for it. She's in a lot of pain. When you're in a lot of pain, generally you want somebody to look at it. So I would say, yeah, definitely let somebody look in the bladder. I would, especially if I were bleeding. But I also want to know the health of the pelvic floor, et cetera, et cetera. So I hope that makes sense. All righty, let's see. Nicole asked, will an estrogen cream help with the bladder wall that is dry? The answer is yes. When you do an estrogen cream vaginally, the estrogen is absorbed through the vagina towards your bladder. All right, let's go back to Facebook here. Pamela said, so many with IC have so many other things that they get with it. Absolutely. Sherry says, I'm wondering more if I have pudendal nerve symptoms when I sit up from laying down. It does relieve me a little bit. I wonder if that's enough to have a doctor test for that. Positional symptoms matter. If your symptoms change, standing, bending over, sitting, and then they improve immediately when you change your position, that's pointing to muscles and nerves. Pamela says, I noticed that they have it with GERD, kidney, gallbladder, appendix. It's interesting, right? So Connie came in and said, can you discuss IC causes and treatment? So Connie, we've been at this now for 4 hours. And so you might want to rewatch the first hour of this meeting where I do that in depth. But let me just summarize here. IC is not just a bladder disease. We're long past the days of thinking that IC is a bladder disease. Why? Because structures outside of the pelvis are often involved, if not the dominant cause. And I can tell you exactly when that happened. It was due to a physical therapist named Rhonda Cotterinos, who back in the early 2000s started going to IC meetings with the doctors, the National Institutes of Health IC meetings. They would convene meetings once every couple of years. I used to go to that. And here she was, a physical therapist, going in and saying, guys, you in your articles, you describe muscles so tight they resemble tight piano strings, but you don't do anything about it. But here's what I've learned in my clinic. When I get these muscles relaxed, their symptoms improve dramatically. Have you looked at the pelvic floor and pelvic floor physical therapy? They laughed at her. I was there. I saw it. So the first meeting, everybody blew her off. The second meeting, something like that happened too. The third meeting, they gave her a spot on the speakers panel. They gave her the very last speaking opportunity in this day-long conference. So it was like at 4:45 for 15 minutes. And most of the doctors walked out. They didn't even listen. 20 years later, she's teaching them. She was right. She was good enough with her information that she convinced the National Institutes of Health to do an IC study on that. And they did. They did a multi-center study of IC patients around the United States. They gave them pelvic floor physical therapy. And the data was shocking. What their data proved is that pelvic floor physical therapy was stunningly helpful in reducing the symptoms of IC. And that paper was published in 2008. And that is the exact moment that the IC world was put on its head, because up to that point, everybody's going, bladder disease, bladder disease, bladder disease. But if it were a bladder disease, why would pelvic floor physical therapy fix it? And that's when they went, uh-oh, maybe muscles are involved. So that was the first thing that happened. Then we had some neurologists who were looking at the bladder and the bowel and nerves, because it seemed like patients were getting bladder and bowel pain or sensitivity in both at the same time. So they called it the pepperoni pizza algorithm in their research study. What they learned is that when you irritate the nerves in the bladder, the nerves in the bowel become irritated too. And when you irritate the nerves in the bowel, the nerves in the bladder become irritated too. Why? Because the nerves merge up here. The nerves for the bladder and the nerves in the bowel merge up here into the same nerve bundle. So we get something called neuro crosstalk. So that was important. Then the University of Maryland did a study on genetics. And what they found is that for some people, IC runs in families. It's like, oh, isn't that interesting? And then they found that central sensitization, this very, very sensitive nervous system, appeared to be the common factor. So we've gone from bladder, then we started looking at bowel, then we started looking at nerves, because why do some IC patients have a wicked sense of smell? That's a brain function, that's nerves. Why do some IC patients get irritable bowel and TMJ? That also is related to our nervous system. So what we know now is that a one treatment fits all approach does not work. What we know now is that bladder therapies fail a great majority of patients who try it. Why? Because structures outside of the bladder, usually muscles, nerves, or other organs, are involved in the pathology or are driving some of these symptoms. So today we're doing something called subtyping. We're trying to give a more specific diagnosis. And in Europe, there are 12 subtypes or 12 variants that they look for. Canada uses a system called input. The United States, we don't have a nationally agreed upon system. We're being slow, which is interesting. Normally we're ahead of the curve, but we're being slow in this. One thing that we agree with in the United States is that Hunner's lesions are different than everybody else. We get that. So that's a clear division. We know that Hunner's lesions are a unique and separate condition. But we also know that some people have bladder wall-driven symptoms from estrogen atrophy, genitourinary syndrome. We know some people have bladder symptoms because of chemotherapy. We know some people have bladder symptoms because a fibroid tumor is pushing on their bladder, or they have endometriosis on their bladder. Okay, they can have fibroid symptoms. They can have bladder symptoms from Tarlov cysts coming off of their spine. So the bladder can be victimized, or you can have a chronic infection in your bladder, like chronic fungal infection. So that's a group of variants. Then we know that a lot of patients get symptoms because they have muscle trauma. They have a long-term pelvic floor trauma that often begins in childhood and never gets addressed, like breaking your tailbone. It's amazing. If you were hit by a car as a kid, you broke your leg as a kid, something like that, that can create the foundation for all of these symptoms. And we know that nerves can be involved, and we know that central sensitization, chronic overlapping pain conditions is a reality. And please, if there's one thing you remember from me today, is none of this is your fault. You have done nothing wrong. There is no shame. There is no blame. You're hurt. Don't think of this as a disease. Think of this as injury. It makes more sense. You can have a muscle injury. You can have a bladder wall injury from chemotherapy. And yes, the Hunter's lesions might be viral infection. That's a possibility, but not everybody has a disease process. A lot of us have injury instead. And the thing is you don't cure an injury, you heal an injury. It's our job to create an environment that will support healing. So if we have a bladder wall injury from chemotherapy or whatever, we're going to follow the diet and we're going to protect those tissues and give the bladder time to heal. Because here's the deal. Healing is always happening. Healing never turns off. Your body is wired to heal 24 hours a day. The challenge is we get in the way of healing. How do we get in the way of healing? Well, if you've got a bladder wall injury, again, from chemo or a terrible diet or ketamine or something like that, and you're drinking coffee every day, you're injuring your bladder every day. Your bladder cannot heal itself if you're pouring acid on it every single day. There's no therapy that can counteract the damage done by a cup of coffee every day. But if you have a muscle issue, diet might not be as important. Instead, you got to do your muscle work. You've got to relax. You got to do your internal therapy. And a lot of us are passive aggressive and we don't do that. And if you've got some inheritance going on, again, no shame, no blame. It's about learning to live in our more sensitive body. It is what it is. So let's see. Jen says, what are my thoughts on bladder hydrodistension for an IC symptom treatment? Hydrodistension is what I call a destructive therapy. The reason why it works is that when you stretch the bladder wall, you temporarily destroy the nerves. The nerves are broken. So the reason why you feel better after you have a hydrodistension is that the nerves are silenced. But the problem is the nerves always grow back. And sometimes more nerves grow back than you originally had. And so we don't want to be doing repetitive hydrodistensions over and over and over again. It's really rare that that's done. We want to instead all that's going to do is deal with the effects. It's not dealing with a cause. It would be nice to find the fundamental root cause of your symptoms, right? Kim says, how are the cysts on the spine diagnosed? I think with visualization, I think that they either do an X-ray or an MRI, something like that. The cysts will often, the cysts can come out of any area of your spine, but sometimes they come right out of the sacrum right here. And this is where your pudendal nerve comes out. And so if you've got a little cyst of spinal fluid that's sticking out, it's going to be pushing on the nerve and could cause some nerve dysfunction that way. Gwen says she'd like the report. It's called the pepperoni pizza algorithm. If you go over onto our website and you search for pepperoni pizza algorithm, I think you'll find the reference to it. Angela says, does a ganglion block help? It might. If you're clearly nerve driven, if you've got pudendal neuralgia, and doing a nerve block is a good diagnostic way of determining what nerve is affected. And if silencing that nerve makes your symptoms go away, then they figured it out. So I just had an epidural 3 weeks ago for my ruptured discs in my spine, and it failed. It did not silence the nerve. And so that's good information that the location that they did, which was my up between vertebrae 3 and 4, failed. It did not work for me, which is very, very disappointing. In fact, it just gave me more pain, which I'm not happy about. It made my back is, I never had back pain with my ruptured disc. I just had leg pain. My leg feels very tight. My knee feels very tight. And there's a numbness that goes down the inside of my leg. So, but it's a valid diagnostic tool and method when they think that a nerve is involved. So let's do this. So for those of you who've stuck it out, this is going to be my giveaway. If you email me, icnetwork@mac.com, I'm going to pick a couple of people that I will mail you one of these books, IC 101 And then I'm going to pick a couple of people to email. I'll email you a PDF version of the book. So if you email me, icnetwork@mac.com, I will get those out to you. And I truly hope that this book helps a little bit. It is an opening salvo. It's going to be very interesting to see how some of the rigid conservatives react to a book that says it's not just a bladder disease, but I think everybody believes that now anyway. But we're just putting it in print. The challenge is going to be your little local doctor who went to med school 30 years ago, was taught it was bladder disease. They're not, they're stuck in the dark ages. We've learned a lot since then. All right. So how long have we been going here? We have been going almost 4 hours. So let's do a last call for questions. Last call for questions. Anybody else have any questions? Been a good meeting. The only thing I missed was a myomectomy. Oh, I should have remembered that. But again, I'm not perfect. As you say, we're guessing. That's the thing I like to say over and over and over again when we have these discussions in these meetings. We're guessing. And you deserve more than a guess. Our challenge here is to get a doctor to examine your anatomy. And that's where it's tricky. That's where you've got to learn as much as you can about your anatomy so that you can walk in and say, hey, I'd like to know if I have a left piriformis injury because I've got pain shooting down my leg or whatever. You cannot walk in and expect the doctor to educate you. They don't have time. And it's a waste of their time and it's a waste of your time. You've got to do your due diligence beforehand and read some stuff. You've got to know where the structures are and be willing to talk about your symptoms. Are they inside your body? Are they outside of your body? Are they to the left? Are they to the right? Are they shallow? Are they deep? What makes them better? What makes them worse? What does the pain feel like? Is it sharp? Is it dull? Does it burn? Is there a vibration? Anything at all like that. Your ability to speak about your symptoms is important. And really, the devil is in the details here. It's often that little symptom that only happens now and then that solves the puzzle here. So yeah, when I sit for more than 5 hours, I get this little tiny fluttering in my left butt cheek. We know what that is. We know what that is. That's a muscle that's being compressed. You've sat too long. What makes it better? What makes it work? All that sort of stuff, okay? All right, my friends, here's your homework for 15 minutes a day. I need you to do something for your bladder, your pelvic floor, follow your diet. If you need to follow the diet, get on your back, go do your pelvic floor exercises. Not Kegels. Kegels make it worse. You got to get the right exercises. Number 2, I need you to do something for your spirit and soul. Give yourself some comfort. You've done nothing wrong. There's no shame, there's no blame here. But you're working hard, you're exhausted, you're tired, you've reached your limit. For God's sake, you want somebody to just give you a hug and take over and make this better. I get that. If you can just spend 15 minutes outside, out in the sun, close your eyes. If you like listening to a sermon, do that. If you like to go walk through the redwood trees, do that. But let's give something that nourishes your soul and your spirit. For 15 minutes a day, I need you to improve your noggin up here. Come on, let's get that knowledge level up. You can read for 15 minutes a day. Do it. Read something about IC, not on Facebook or in a support group meeting. Come on, I need real educational information here. You are what you read. If you're reading on Facebook, you're stuck in drama. I need you to read about the anatomy. I need you to read about the nerves. I need you to read about the related conditions. Let's get this knowledge level up. And last but not least, for 15 minutes a day, although personally I think it should be an hour a day, I need you to laugh. Because laughter minimizes brain. When you're laughing, your brain knows your life is not at stake and your brain will minimize that pain. But if you're anxious as hell and catastrophizing, your brain is going, oh my God, her life is at stake. It's going to intensify your pain because it thinks that something very bad is happening. It thinks that you're fighting for your life. You're not fighting for your life. You've got an irritated bladder or injured pelvic floor, sensitive nerves, et cetera, et cetera. So let's get some laughter in there. Do something fun. I watch TikTok, although I have to, the animal stuff on TikTok is starting to drive me crazy. But, you know, anybody want to learn TikTok dances together? I'm dying to learn some of these TikTok dances. You know, why not? All right, my friends. This is, okay, this is the new hug because these are hearts. So I'm sending you all big, giant